Bismillahirrahmanirrahim. Assalamu alaikum warahmatullahi wabarakatuh. A very good day to all the respected speakers and the panelists and audience who have come across for this wonderful scientific session organized by Neonatology scientific team of UAE in association with Emirates Specialty Hospital and Pathophysiology and KZ. The topic of the webinar today is neonatal neurology, and a galaxy of speakers have been arranged from the neonatal team of UAE, along with the help of Dr. Amit Mathur. So let me just introduce the scientific committee of today's program. So Dr. Monica Kaushal. So she is the consultant neonatologist and head at Emirates Specialty Hospital, Dubai Healthcare City. Dr. Rajesh Sharma, consultant neonatologist at Al Cornish Hospital, Abu Dhabi. And Dr. Sridhar Kalyan Sundaram, head of neonatology and consultant neonatologist at Danlat Amrat, Emirates Hospital, Abu Dhabi. Along with, we are very grateful to Dr. Amit Mathur for his coordination with all the speakers to arrange for today's program. Dr. Amit Mathur is a professor and director and division of neonatal perinatal medicine and Department of Pediatrics, St. Louis University School of Medicine. And he is medical director at NICU, SSM Health Cardinal Glennon at Children's Hospital, Missouri, United States. Myself, Taufeeq Ali, I'm a country business manager of New Country Healthcare. So I request Dr. Sridhar to come on and give the introduction speech.
Thank you,
Dr. Sridhar, please.
Yes, thank you, and good evening, everyone, and welcome to join us for this excellent symposium on neonatal neurology. The National Neonatology Forum is well established in service for the newborn, and along with the Indian Academy of Pediatrics neonatal chapter, both are doing a great job in furthering neonatal care all over the country. And we are very privileged to have Professor Siddharth Ramji here with us, who is now taken over as the president from none other than Professor Ashok Diorari. And next year it will be my privilege for Professor Praveen Kumar as well. So we are privileged to have such excellent academicians leading the NNF. And we will be going through, I'm sure, a lot of improvements in the way we are delivering neonatal care in India. This webinar has been organized with great support from Amit Mathur, and we are privileged to have his support. And the faculty today, all of you must have seen, is an amazing faculty, all of them extremely experienced in the field, and the topics are very interesting, ranging from neurodevelopment in premature babies, perinatal asphyxia, neonatal seizures, and outcome in term babies. And I'm sure we'll have an excellent session with discussion. In terms of housekeeping, I mean, we need to put the questions in the session for the sessions, because the discussion will happen soon after the individual lectures. And if any questions are addressed, and by typing the answers, we will do that. And if there is time for the questions in the discussion session, we'll cover that as well. We expect more than 1,000 attendees, and hopefully we'll have a great session. Now it's my privilege to introduce Professor Siddharth Ramji. All of you know him. He is an eminent academician. He was the Dean of Maulana Azad Medical College for 3 years before retiring, and he's the current NNF president. And he has an excellent career. All of you know his landmark work on oxygen at resuscitation, or room air at resuscitation rather than oxygen at resuscitation. So I'm not going to go into much detail on introducing him, because he's an extremely renowned, well-known figure all over India. And we request him, we thank him firstly for honoring us with this presence today. And we request him to offer a few words before the webinar. Over to you, Professor.
Thank you, Sridhar, for those very kind words, and a good day to all of you. I realize that you people are here on this platform across several time zones, so I couldn't find a more appropriate way of greeting everyone. At the outset, I want to thank all of you for having us over here. I'm particularly very honored to be part of the rather exciting symposia that you put together. It's exciting, I think, for more than one reason. As you said right at the outset, we have some of the best minds in neonatal neurology who are going to speak this evening. And I don't think it's often an opportunity that one gets to hear these great minds. Not only that, I think you people have done a great job allowing over 1,000 people, I understand 1,000 participants, who would get some kind of an opportunity to actually interact with these people. We have all been transiting through improved newborn survival, and also the period of viability has been progressively coming down further and further down. And so I think the main concern that all of us eventually have is that we want our kids to be intact in terms of cognition and maximize their adult outputs. And nothing could be more important than looking at the neurology of these kids. And I think that the participants today will have much to learn from these wonderful legends. And I'm sure that each one of them would have an opportunity to take back important lessons that they can take back into their own personal practice and hope to do something better for the babies they salvage. So thank you so much for having me over, wishing you all the best. And I would like to stand between this wonderful symposia and the participants. Thank you, all of you.
Thank you, sir, for your kind blessings. And you said it very clearly that we sow the seeds for the future, and anything that happens with the brain has an impact on their whole life more than any other organ system. So without doubt, this is one area that affects the parents, affects NICU team, and whatever we do from the start, we have to do it in the best way possible to protect the brain. So neuroprotection is the key. And now I'll move on to Professor Amit Mathur, who will have, he has had a huge role in organizing, as Taufeeq mentioned, and without him, I don't think we would have coordinated so well. And he and Monica did a great job in getting together our galaxy of speakers. He did his medical training as well as pediatric training in India and Delhi, and then he moved to UK, where he worked in Edinburgh, completed his MRCP, then did his fellowship in St. Louis, and he's actually the founding member of the Newborn Brain Society. He's currently Professor of Pediatrics and Director, Division of Neonatal Perinatal Medicine at St. Louis University. His role today will be like, holding us together. So he'll have a kind of role where he introduces the moderators. And for sake of time, we have taken a conscious decision to keep the introductions to brief ones, so we spend more time on the academic part as well. So over to you, Professor Mathur, and thank you for all your support.
Good day, everyone. Thank you, Dr. Sridhar, for the kind introduction. I actually have the unique privilege of having trained with Dr. Ramji, so it's great to see him almost 35 years ago at Safdarjung Hospital. But I also have had the privilege of collaborating and working with a number of speakers today. And I really want to thank them and acknowledge the time zones that we're spanning our speakers. So Dr. Anderson in Melbourne, it's midnight for him, but he's agreed to speak. The rest of the speakers are in the US and Europe. So I'm not going to stay any longer between our speakers and the audience. I think we already have over about 600 participants online. So I'm going to stop and hand it back to you, Dr. Sridhar. Actually, I'm going to introduce the first moderator. So we've had a slight change in the program lineup. Instead of Dr. Anderson, it'll be Dr. Terrie Inder, who will be starting our series, followed by Dr. Anderson. I'm going to introduce the moderator for this session, Dr. Junaid Khan, who is the Director of Medical Education and Director of the Pediatric Residency Program, and a Senior Consultant in Neonatology with adjunct faculty appointment at Khalifa University and Mayo Clinic in the US. So over to you, Dr. Junaid Khan.
Hey, thank you, Amit. Thank you very much for kind introduction. So it's my honor and pleasure to introduce Dr. Terrie Eleanor. She's a dual boarded newborn medicine physician and the child neurologist. she is taking the clinical service, so she is intensivist. So don't worry about that. She's not only the neurologist, but the neonatologist also. Her research mainly about the high-risk brain injuries in the high-risk infants, and they are using all kind of technologies. One which is very close to me also, the NIRS, the near-infrared spectroscopy, and electroencephalography and MRI. She moved to get a new role in 2013 as the chair of the new department of the pediatric newborn medicine at Brigham and Women's Hospital in the Boston, where she is working now. Her main targeted and research is the timing, mechanism, and impact of the cerebral injury and altered cerebral development in the human infant. So right physician, right doctor for the right topic, which is the preterm brain injury. Over to you. I must say, I cannot say the podium over to you, but the virtual screen over to you, Dr. Inder.
Thank you so much for that kind introduction, and thank you so much for the capacity to be able to be here this morning with you and present. And I do apologize for the slight change in the order, but I'm very grateful to Dr. Mathur and to all of you for the privilege of being here this morning. My topic isn't small, as you know, brain injury in the preterm infant, so off we go. We know the types of small babies that we are caring for, and as you will hear from one of the speakers today, the outcomes of our preterm infants remain challenged, and these are very broad numbers that I know Dr. Anderson will do a much more elegant job of taking you through. But although many of our children now don't suffer from significant cerebral palsy, many still have clumsiness, require extra help in school, and have a high risk of some behavioral challenges throughout their childhood years. So why? That's what I'm going to focus on. Why do these children face these challenges in terms of their motor, cognitive, and behavioral and language development? There are two big areas, and we're going to focus on the upper one, which is brain injury. I will briefly touch on the fact that that's not the whole answer, but when we think about brain injury, what are we talking about? And there are three main forms of brain injury we'll focus on this morning: intraventricular hemorrhage, cerebellar hemorrhage, and white matter injury. When we think about intraventricular hemorrhage, we know that it is graded traditionally in this nomenclature with numbering, where grade 1 relates just to hemorrhage within the fragile capillary network in the germinal matrix zone that lies within the caudothalamic groove, and that there is, by definition, no intraventricular blood as the hemorrhage remains contained within the germinal matrix. At grade 2 and 3, this can be somewhat difficult sometimes to distinguish. On the upper panel here is grade 2, where there is now blood within the ventricle, but either without significant dilatation or with the amount of blood occupying only a small amount of the space in the ventricle. Whereas grade 3 typically has dilatation and a lot of hemorrhage occupying the space. The so-called grade 4 is really not about the hemorrhage in the ventricle. It is about a complication that occurs with a venous hemorrhagic infarction, where you can see here that what occurs with a lot of blood in the ventricle is occlusion of the terminal vein with rupture of these medullary veins, causing a venous hemorrhagic infarction. Why is it important? Because it's still common. And in fact, it's unfortunate that really we've made very little progress in this disease over the last decade. This is data from the Vermont-Oxford network over a period of 10 years. And you can see that for infants less than 1,500 grams, the rates overall are pretty static at 25%, with only 10% of that accounted for by this lower grade 1, and the rest being accounted for by higher grades. This was also shown in the Neonatal Research Network, where they looked at high-grade hemorrhages here in close to 35,000 infants over a period of close to 2 decades, and showed that despite the fact that our treatments have changed, more antenatal steroids, less invasive resuscitation, that our rates of severe intracranial hemorrhage have remained relatively static. Why is this, and what causes this disease? What causes this risk of injury? Well, there are some factors we can't influence, and we'll talk about this. The more immature you are, the more you are vulnerable to this disease because of the vascular immaturity. If there's been risk factors prior to delivery, particularly maternal inflammation, or anything that may require you to have a lot of extra resuscitation around birth that has put you at risk of really a form of perinatal asphyxia in the preterm, often we can't influence that. But these other factors in red, particularly around cardiorespiratory stability and metabolic stability, we can influence. And these things lead to a risk of intraventricular hemorrhage. We know the immaturity of the germinal matrix is a major risk factor. The germinal matrix itself exists as the source of neural progenitors from around 10 to 20 weeks, and then becomes a supplier of both oligodendroglial, the sort of myelin wrapping precursors we'll talk about a little bit more, and GABAergic neurons. Its maximal size is around 22 to 23 weeks, and then it starts to regress to fully involute by term. And it's a very delicate area of blood vessels. It's very prone to rupture, and it sits in an area that's a relative watershed in the immature brain. Vascular factors are really key to the etiology of this disorder in two ways. First of all, that the immature brain has very little ability to auto-regulate. And so whatever changes in systemic blood pressure are happening, the brain may see that and will see this. On top of that, we know that the brain is both vulnerable to both decreases and increases in cerebral blood flow, and that many of the factors that happen in normal neonatal intensive care, particularly in the first few days of life, influence this both vulnerability to ischemia and reperfusion injury. And that's shown here in a schema that Dr. Volpe and I tried to put together for his last version of the book. You can see on the very left this time sequence of the first phase being more of an ischemic phase, the second phase being more of a reperfusion, the first phase being characterized by these cardiorespiratory factors that often we can't see, that lead to decreased cardiac output, to impaired venous drainage, and to ventilatory instability, leading to poor perfusion of the brain and relative ischemia to this poor germinal matrix. However, we do see some things on our measurements, and because of that, we often intervene, and some of those interventions may be the factors that lead to unfortunate reperfusion injury and then the rupture of the germinal matrix occurring in that first 72 hours of life. There's data to support this, and this is beautiful data that the lead person of this session, Dr. Mathur, with one of his key mentees, Zachary Vasulius, undertook with many, many measurements using neuroinfrared spectroscopy in immature infants, showing, as you can see here, this dark line being the severe IVH, showing compared to the light gray line, both undershooting in this first 40 hours and then overshooting of what the infants who did not have IVH. In other words, the infants with severe IVH spent more time both below and above what we would think of as appropriate mean arterial blood pressures. This is made worse by the fact that many of the infants will have impaired ability to buffer these mean arterial blood pressures and the impact on their brain. And you can see here on the top panel that of an infant with IVH, below that with an infant without. And you can see how the brain, in terms of the blue, in terms of cerebral oxygenation, is seeing all of the changes in the mean arterial blood pressure, unable to buffer those changes in any way. This aligns with the timeline for intraventricular hemorrhage in that we know that about half of this is visible on day one, and most of this will occur within the first 72 hours of life, where it's pretty rare to see new hemorrhage after that time, although of course the hemorrhages can extend. The maximal extent of IVH is usually present by day 5. We minimally do an ultrasound on day 1, 3, and between 5 and 7 days. And this helps us to understand, particularly on the first day of life, did this intraventricular hemorrhage occur around the immediate perinatal time? And should we be looking at our delivery room and our prenatal management? Or did this occur not then on day 1, but sometime after day 1? And should we be looking much more focused on the first 48, 72 hours of the neonatal management? And certainly other groups such as Dr. DeVries, who's led so much of this work, will tell you that doing the ultrasound every day will give you even more information. The neurological consequences of IVH extend more than just the blood. Obviously, the destruction of the germinal matrix has impact. The blood can impact the white matter and the cerebellum. And in terms of the outcome, we know that 2 key complications moderate a lot of the neurodevelopmental consequences. That is the likelihood that you will have this venous infarction and the likelihood you may develop hydrocephalus. So you can see here, when you think about this hemorrhage, it's not just the presence of this blood that is the problem. It's the fact you've destroyed the germinal matrix. The blood itself activates a lot of other aggressive reactions within the brain that have impact on the white matter. And indeed, if the blood goes down around the cerebellum, you'll also see external effects on the external granular layer of the cerebellum. The outcomes of these babies do vary depending on the severity, obviously, of the hemorrhage. The more milder forms of hemorrhage, as you can see here, the grade 1, appear to have less impact, obviously, than the higher grade 3 and 4. And the way I try to think about it is grade 1 really probably doesn't have direct impact, except it mediate impaired neurogenesis in the most immature of infants. Grade 2 does increase the risk of disability, and part of this is that we are a little bit poor at delineating how much blood is in that ventricle and what impact that blood may be having in all regions of the brain. Mortality clearly increases as the grade increases. And what I'd like you to think is that grade 3 and 4 really have actually pretty similar profiles, and that what you're looking at is the size of that venous stroke and the amount of hydrocephalus or ventricular dilatation. Remember that the amount of intraventricular blood will occlude that draining vein and lead to this risk of this secondary complication of this venous congestion infarction, that the outcome really relates to how big that hemorrhage is. And this is data that shows that when the hemorrhage is extensive, even if it's unilateral, that the chances of dying or of major motor or cognitive defects are much, much higher than if the hemorrhage is localized. And this was most beautifully shown by the largest series that was published by another speaker today, Dr. DeVries, who's contributed so much in this area, showing that really for infants who survived, when the hemorrhage was focal within the parietal area, which is by far the commonest area, and if these infants survived, of which approximately 70% or 60% did, then the chances of adverse outcome were really restricted to the motor domain, and they were predominantly restricted to unilateral spastic cerebral palsy, of which a significant amount was mild. So you really have to be careful when people start talking about the prognosis related to this so-called grade 4, and think of it very much as a stroke lesion, a venous stroke, and think of the outcomes in terms of the size of the stroke, the area of the brain that's involved, and the impact. The other complication that modifies outcome is post-hemorrhagic ventricular dilatation. If there is any ventricular hemorrhage, intraventricular hemorrhage, the chances the ventricles may dilate is about 50%. If you do get this slowly progressive ventricular dilatation that occurs in about half of the cases that dilate, about half of those you will be thinking about some form of intervention. So if you take overall all of the babies that may have intraventricular blood, around 15% or so at least, you will be struggling with the decisions of whether to intervene. It doesn't matter, as I've said, whether it's grade 3 or grade 4 hemorrhages in terms of the frequency of this condition. And that is significantly, obviously, more common than if you have the lower grade 1 or 2. How do you manage this condition? And we don't have time today to discuss this, but I would refer you to this review article that I had the privilege of working with Linda de Vries on, that looks a lot at the measurements of the ventricles, which need to be undertaken and systematically followed, because we know, and this was work that Dr. Mathur contributed to, that the larger the ventricles get, the worse the outcome for the baby. So you can see here on the lower axis that these are the measurements from the ultrasound that were the maximal measurements for the babies while they were in the neonatal unit associated with their 2-year outcomes. The bigger those ventricles get, the worse the babies will do. And this again has been shown now in the randomized controlled trial that was beautifully done by Dr. de Vries and other comparative work across North America, leading to recommendations that one should be monitoring these measurements in any baby with intraventricular blood, plotting them at least 2 to 3 times a week, and then making decisions about, depending on which zone the baby lies in, as to what the next steps may be, considering a lumbar puncture and when to consider that, considering neurosurgical interventions with a temporizing measure, such as a reservoir or a subgaleal shunt. The other form of brain injuries that we'll briefly touch on are that of cerebellar hemorrhage, which is often missed on cranial ultrasound, particularly if it's small, compared to routine MRI studies, which more commonly detect these hemorrhages in around 15 to 20% of infants. What has been shown on the Cochrane analysis, or the meta-analysis of this, is that particularly for those larger hemorrhages, that they are associated with both motor and cognitive impairment. The commonest type of injury seen in the preterm infant is that of white matter injury, and it can be very commonly seen to be mild with a couple of little punctate scars, as you can see on the far left, moving up in grade to linear scars, or now rare, fortunately, the severe cysts. Why does the white matter get so commonly injured? It's because the white matter is maturing rapidly. From that very immature neural stem cell, it produces this very vulnerable cell called the oligodendroglia, which is destined to form a complex cell after it goes through its pre-oligodendroglial stage to produce myelin, which is initially immature and then mature later in life. This pre-oligodendroglia is extremely sensitive little cell in the immature brain and is present in the immature brain between about 24 weeks of postmenstrual age and 32 weeks. There are 2 major mediators of white matter injury: ischemia and reperfusion with a similar vulnerability to IVH, and inflammatory mediated injury is also important here, particularly perinatal sepsis, postnatal sepsis, and necrotizing enterocolitis. Both white matter injury and intraventricular hemorrhage, when they are high grade, as shown, really do have a detrimental effect, particularly on motor development. But as Peter Anderson has shown beautifully, it's more than just motor development, and this is the association between white matter abnormalities at the time the baby leaves the neonatal intensive care unit and school-aged outcomes. And you can see that both moderate to severe and even mild white matter abnormalities, as shown, have an impact on many different academic performances, as you can see. You can also see in this particular slide that it's not just the white matter injury, but also abnormalities that were seen in the deep nuclear grey matter and the cerebellum. And when we think about white matter abnormalities, it's important, as Dr. Volpe has very beautifully described many times, that when you injure the white matter, you're not only injuring this local area of the brain, as shown here in yellow, but you're injuring everything it's connected to. So you can see when you put that big yellow blob over the other side, that connection, that cable is going from the thalamus all the way up to the cortex and connecting between the hemispheres. And when you cause injury in this area, you will cause up and downstream effects on the connections to those critical neurons and the way they function. In addition, as you can see, those migrating cells that were going to come from that germinal eminence are also further affected. So briefly, how can we move forward? We've got this disease injury that's so common. We haven't made any impact in it. How would we move forward now to try and improve the outcomes for our babies? How could we prevent injury? Well, as I've said, I believe a lot of this now comes down to ischemic reperfusion injury, and there is some data to try and help us. We need to be able to look to what period the brain is most likely to go through this, and it appears to be the first 72 hours of life. I do believe that brain monitoring will be essential, but if we can closely monitor all aspects of the care that we are giving, including blood pressure, cerebral perfusion, ventilation, CO2, fluid status, prevent any fluctuations. That needs to begin prenatally with steroids, continue in the delivery room with delayed cord clamping and appropriate resuscitation. And in the NICU, care around the time of surfactant administration, which has a dramatic cardiorespiratory impact, and blood pressure management. A beautiful study, again led out by Linda de Vries, looked at a nursing intervention in 561 preterm infants. And what they did was compare both pre and post the intervention. This intervention tried to minimize these fluxes by maintaining a central headline position, tilting the incubator and avoiding the head going down or sudden elevation of the legs, and avoiding rapid flushes or rapid withdrawals of blood. They did this starting after birth for at least the first 72 hours of life. And look what they showed, a dramatic reduction in new or progressive severe IVH or cystic PVL. How else can we reduce brain injury? Monitoring. And again, this beautiful review by Zach Vasulius looks at the complexity around being able to monitor cerebral perfusion and oxygenation. But we know when we do monitor that we can see differences. And again, this is one study looking at intraventricular hemorrhage associated with these measurements. And you can see that the black boxes are the infants with IVH. They had lower cerebral oxygenation and they had higher extraction. They were needing that oxygen to the brain and they weren't getting it. Again, if we're going to try and untangle and measure what we need to do as clinicians at the bedside, we need more information. And to get that information, we really are going to have to start to untangle modern hemodynamics with more diagnostic certainty than we've had. And this has been the work of targeted echo for many years to try and give us less diagnostic uncertainty so that we can use our therapies more judiciously around hypotension, the duct, and ventilation. Are there other treatments coming? For decades now, we have been looking at the mechanisms of inflammation, oxidant stress, and glutamate excitotoxic injury to try and reduce the cascade of injury in the preterm brain. And unfortunately, there is no silver bullet here, and we are yet to find something that has made a dramatic impact. We can also consider, though, that we can improve outcomes if we do indeed have injury. And I would, make sure that we all consider rehabilitation as an important part of the type of care that we can still provide to our infants, both within the NICU and after discharge. And indeed, we know that injury has a particular impact on motor outcomes, and that physical therapy directed in the NICU may be particularly helpful, particularly if it engages the family to be able to continue with these treatments after discharge. Finally, I'll just say that there's other things happening in the preterm brain apart from injury that we still have to be mindful of to improve outcomes. And we know when we have studied it, and again, this is beautiful work that's been done by Peter Anderson and his beautiful cohort in Melbourne, looking at the differences between infants without brain injury and those who are born full term. And you can see systematic differences in the development, particularly around the temporal lobe and the dorsal prefrontal cortex, that are not related to injury, but probably related to the many experiences and exposures that our infants have that are so different from what they were meant to have. So in terms of improving outcomes, injury is a big factor, and you can see here it's really in dark red, and it is critical in this first 72 hours of life. And I think the keys are going to be our ability to monitor the brain, to have more insight into cerebrovascular physiology and overall cardiorespiratory physiology to target our treatments, and potentially also to have target elements of neuroinflammation. This is part of a spectrum of improving outcomes that, as I say, I don't wish to forget about the importance of brain development in the NICU exposures and the time after discharge. But today, I hope you can take away that brain injury remains very common in the preterm infant, with rates of between 20 to 50% when you combine IVH, cerebellar hemorrhage, and white matter injury. Greater immaturity equals greater risk, but more mature preterm infants also remain vulnerable, particularly for white matter injury. Most injury is occurring during the greatest time of cardiorespiratory instability in the first 72 hours of life. And we really now have to frame shift our knowledge. And this is going to require information. We are not voyeurs. We cannot see inside a skull and a baby to understand these things without using technology to assist us. And if brain injury does occur in your babies, please use the words neurorehabilitation or rehabilitation for them, just as you would at any other time of life. This requires a team approach. We as a discipline, we as a NICU, we as a group of providers are going to have to own the fact that our brain injury rates are high and have not improved. We're going to have to learn how to use these monitoring techniques. We're going to have to learn about how we can improve our outcomes and take a multidisciplinary task force approach to make a difference. And with that, I thank you for your attention and would be happy to take any questions that I may be able to answer.
Okay, thanks a lot, Dr. Terrie Inder. Thank you very much. It's a very nice covering all the topics. We have few questions, and then we will continue with our discussion. One question is from the audience: is brain injury in preterms with severe IUGR is any difference?
That's a very good question. And what we have found in the severe IUGR infants, anecdotally, and I would love to have other speakers speak to this, but you know, these infants are often stressed in utero, and they tend to almost prematurely mature some of their responses or dismature them. So if anything, although they may be vulnerable to the cardiorespiratory instability, particularly their respiratory disease can be extraordinarily difficult to manage in those early hours or days. The risk of brain injury doesn't necessarily go along with that to the same extent. So their sort of vasculature may have had that extra maturation to have prevented as much severe impact. Having said that, I think there are other consequences of their severe growth restriction on their long-term outcomes that may offset that, unfortunately. But they have not been well published as a subset of preterm infants that I'm aware of.
Sure. Another question is about the outcome of cerebellar hematomas.
So cerebellar hemorrhage is a very interesting topic, and indeed another speaker on here, Dr. De Vries, has published beautifully on this too, and it's been our experience as well. These large hemorrhages are the ones that have the greatest impact on later outcomes. They are very commonly concurrent with intraventricular hemorrhage. So if we see and they are much commoner in the more immature infants, less than 27 weeks gestation at birth. So if you have a small baby who has a significant intraventricular hemorrhage, you should be looking very carefully at the cerebellar area, because often it will co-bed with a significant cerebellar hemorrhage as well, because the mechanisms are very similar. These larger hemorrhages also are associated with increased risk of motor and cognitive, and for us in particular, language risk and autism risk has also been the thing that has been observed.
Yeah.
So the smaller hemorrhages that occur in the germinal matrix of the cerebellum, similar to small germinal matrix hemorrhages supratentorially, do not appear to have as much impact on the baby, and mainly because these are right externally on the cerebellum.
Okay, so there is a couple of questions. I am actually trying to make it one question regarding the post-hemorrhagic ventricular dilatation. Okay, so first thing, you are using the ventricular index, and how often you are doing the ultrasound or tapping? Let's say if you don't put the reservoir, then how often? Because there are chances of infection also there.
Yeah, so again, there's a better expert than I on this panel to be able to speak to this, but our experience and everything you will find beautifully summarized in that review article in terms of the guidelines you should consider for your unit. What we would say is that if the baby has intraventricular blood, we automatically begin monitoring 3 times a week. So every second day, we measure all of the ventricular measurements. We measure the anterior horn width, the ventricular index, and the thalamo-occipital diameter. They are plotted. We have in that article an online graph that you can go to, and you can use that to plot. And if we see that the measurements are increasing, then we consult with neurosurgery early to be able to at least begin the discussion about the timing of when we would trial a period of lumbar punctures first. We would do at least 2 or 3 lumbar punctures as temporizing measures to see if these would intercept the progressive nature. And then if that does not work, then we would be considering the insertion of either a reservoir or a subgaleal shunt. And this approach, as was shown in the ALVA study, is associated with a dramatic improvement in terms of the fact that the children in that study, their IQs were in the 90s. In the North American studies, where we wait and watch and scratch and will not engage, the IQs are often in the 60s or 70s. It's very, very sad that we could be making a difference to these children. Infection rates are low if you are systematic about the way that you undertake all of the surgical interventions and the drainage of the reservoirs.
Yeah. There's an interesting question that what is the connection between white matter injury and the severe post-hemorrhagic dilatation?
That's a very good question. And we do believe that the stretching of the immature cables with the presence of the hemosiderin in the blood, the iron, together cause a lot of further injury to the white matter. And indeed, these children with post-hemorrhagic hydrocephalus do have significant injury to the white matter.
Okay. Also, there's a lot of question about the timing, if it is happening early or the late. So for example, there is a question about early onset hemorrhage and the late onset hemorrhage. Is there any difference in the outcome?
Yeah, so that's a very interesting question because a lot of the impact of the hemorrhage is related to these complications. So the size of the hemorrhage and the complications that are mediating the outcomes, and also the level of maturation of the baby at the time of the hemorrhage. In our experience, late hemorrhages are rare. They really only occur with infants who've had a massive cardiorespiratory collapse or overwhelming sepsis and hemodynamic instability associated with that. The period of IVH in most people's hands is dramatically this first 72 hours of life.
So because we have an audience from all over the world almost, and there is a questions, 1 or 2 questions from the low income resource countries that they are asking that we have not that expensive tools like NIRS, AEG or end-tidal CO2. Is there any cheaper tool to monitoring the brain injuries satisfactorily?
Yeah, I mean, I think that things that you can do in low income settings are follow the guidelines that are coming through from, for instance, this bundle that showed that head position, avoiding withdrawing and flushing. Read and take the information that is given from these people who are able to monitor and guide practice, delayed cord clamping, these simple measures that have been shown to improve cerebral perfusion. If you could apply those and continue to learn from those, as we and others, particularly people like Dr. DeVries, Dr. Mathur on this, try to develop measures and methods that can be applied no matter where you are in the world.
Yeah, I think this IVH care bundle, if they follow it, it helps a lot. Only the positioning and how to take the blood from the UAC and, because of the cerebral autoregulation. There's one
and monitoring CO2 as best you can, even if you don't have end tidal.
Exactly. So now back to the monitoring. You specifically said in your thing that you are using the NIRS also. So you start monitoring from the day one of the life?
Yes, we start monitoring. We start monitoring straight after delivery, once the baby is stabilized with the central lines in usually, and we will monitor right through the first four days of life at least. Our nurses place the near-infrared monitor on, just as they would place other electrodes on the baby.
There's one question which is a lot of controversies in our setting, and also when I was in the US also, that to do the ultrasound in a very sick or very premature baby at day one, I mean, some people do, some people don't. So what do you think about that? That it is mandatory to do the day one, or we can carry on to day 3 and then we will do the first ultrasound of the head?
I actually strongly believe it's very important. And we just wrote an article on neuroimaging with Dr. DeVries, actually in the premature infant. And one of the letters we had back stated that most of this hemorrhage has occurred by the time you do the first ultrasound. And our point was that you don't know when it may be occurring, so you don't know where to put your energy. If really, as these authors noted, most of the hemorrhage is occurring by 12 hours of life, if you are seeing most of your hemorrhage by then, you need to look at your prenatal and delivery room care, because something is happening in those babies. For us, that is not the situation in Boston. Most of our first ultrasounds in the first 12 hours do not show major hemorrhage. Our major hemorrhages are occurring between 12 and 72 hours. And that means it's in our hands. It's in the neonatologist's hands that we need to focus our energy. So I believe it's very, very important. And I think people often say we don't want to handle the babies, the same with the targeted echo. I think you need to look at who is doing the ultrasounds. You can do these very gently, very easily, with minimal handling of the baby.
Yeah, to me also, if the baby is ventilated, I think it's a very important to do the ultrasound early as much as possible. But if the baby is on non-invasive ventilation and the big, that I don't know, but anyway, there's a similar question about the head circumference, orofacial circumference. Is a useful indicator, or is a fruit test thing?
Yeah, certainly it's challenging, particularly when the babies have got CPAP hats and all of the, and there is a lot of handling that goes on to get. I personally find feeling the sutures are just as helpful in terms of knowing whether there may be significant changes in the intracranial pressure. So it's difficult sometimes with the head circumference, but it is important to continue to measure the head circumference. I don't want to send that message, but feeling the head and not disturbing the baby as much is maybe as important.
Similarly, like Nils, you answer, when you start monitoring or you putting the AEG on those babies?
So we don't routinely do a lot of AEG in our preterm population unless we are concerned. If we are concerned that the baby may have had major neurological insult, or we are worried about seizures, then we will start AEG.
Sorry,
okay.
I think we have
Sridhar is here, so I have to stop, but otherwise we will continue whole day.
No.
Terrie. Sorry
I know
about that.
Professor Inder has some commitment now, but if you can come back later and answer the questions in a type format, that would be really great.
Sure.
Thank you so much. Thank you,
So
guys.
many questions, so many interesting questions. So if you find time, otherwise, I'm sure other panelists will be able to answer that as well. So wish you a great day and thank you, Dr. Junaid. Excellent.
Thank you.
My privilege. Thank you. Thank you so much.
Thank you. I hand over to Professor Mathur again.
So I'll be introducing the next moderator, Dr. Khalid Atawi, a great friend. He is a consultant neonatologist in a very busy Latifa hospital, and he has completed his master's and PhD degrees from Shams University and master's in healthcare management from Royal College of Ireland. He is actually got a lot of publications, and he is a editorial board member for many journals, and his main interest is in ventilation, nutrition, and brain injury and protection. Welcome, Dr. Khalid.
Thank you, Monica, for the invitation and this successful symposium. Let me take the opportunity to introduce Dr. Peter Anderson, who is a professor of pediatric neuropsychology at the Turner Institute for Brain and Mental Health, School of Psychology, Psychological Sciences, Monash University, and the director of Victorian Infant Brain Studies team based at the Murdoch Children Research Institute. He is a psychologist interested in the cognitive development of children, and for over than 20 years has focused on understanding the mechanisms underlying cognitive and learning problems in children born very preterm. His research involves observational outcome studies, longitudinal neuroimaging studies, and numerous randomized controlled trials assessing the long-term benefits and consequences of obstetric, perinatal, and developmental intervention. Dr. Anderson will be giving us a talk about the ongoing neurodevelopmental challenges facing the children born very preterm. So welcome, Dr. Anderson.
Thank you very much, and good evening to everybody. Hopefully you can see my screen now and hear me.
Yes.
So, yeah, thank you. It's great to be part of this symposium. It's a great lineup of speakers, and I'm very pleased that there was space in the program to talk about long-term neurodevelopment. I suspect that most of the audience has a fair understanding of what some of the challenges are that face children born very preterm. So I thought tonight what I would do would be to focus on 5 points, which I think are particularly relevant to today, because there is a huge amount of research out there in this area. And I think these particular points I'm hoping will help you in your interpretation of this enormous amount of literature, and ultimately help you with counselling families who have a very preterm child. Now tonight, I'm going to be focusing on the challenges facing children born very preterm, but the actual concepts I'm going to be talking about are very relevant for pretty much any neonatal condition which impacts on the brain. And I'd also just like to, before I get into the presentation, note that the data I'm going to be presenting today is all data from studies which I've been involved in, but there are many, many groups around the world which are doing great long-term neurodevelopmental research, and most of the points I'm discussing tonight could be supported by research from many other groups from around the world. Why is that not? Sorry. Okay, here we go. So, as I've already implied, there is a huge amount of research in this area, and in my mind, the core domains which people are focused on are sensory, motor, cognitive, and educational domains. And there is, in my mind, a huge amount of evidence to indicate that there are challenges for children born very preterm across all these domains. For example, children born very preterm have increased risk of visual acuity problems, visual perceptual issues. They're more likely to have motor problems. You'll probably know that about 1 in 10 will develop cerebral palsy, but on top of that, another 40% will develop a condition called developmental coordination disorder. In terms of cognition, children born very preterm perform below children born full term as a group on tests of IQ, attention, information processing, memory, executive function, language, and any other cognitive domain you want to look at. And not surprising, given all this, that these children are at risk of difficulties at school on standardised tests of basic educational skills such as handwriting, maths, reading, and spelling. The group performs more poorly than children born full term. They're also more likely to repeat a grade at school and need support at school. Now, most of the research in the area has focused on looking at mean group differences. So when you do a literature review, what you'll find, and if you look up research that I've been involved in, you'll see a lot of means and differences between the means. But one of the things I do want to focus on today is going beyond looking at mean group differences, and hopefully that can help us in better understanding long-term outcomes at an individual level rather than just at a group level. So these are the things I want to talk about today: whether neurodevelopmental outcomes are improving with time. I want to talk about looking at rates of impairment rather than mean group differences. I want to talk about individual profiles, developmental stability, and mental health. So starting with changing neurodevelopmental outcomes. Are we seeing improved outcomes with improvements in obstetric and neonatal care for these women and babies? I've been fortunate enough to be involved with the Victorian Infant Collaborative Study Group for a number of decades. This is a group which has been recruiting cohorts of children born extremely preterm in the state of Victoria in Australia for a number of decades. And this is a group which was headed by Lex Doyle for a long period of time, and more recently by Ginny Chong. And in a recent paper, which was published last year, where we looked at 2-year outcomes, we compared the 2-year outcomes for our 4 most recent cohorts born in 91, 92, 97, 2005, and 2016. And unfortunately, I don't think you can, oh, here we go, you can see my mouse now. So if we look at survival across these 4 eras, you can see that there has been a gradual increase in survival, with the most dramatic being from the early 90s to the late 90s. And so that's great news. Cerebral palsy, there's been some talk about that in the literature, that there's been a reduction in cerebral palsy. We have not seen that for a long period of time, but most recently we have seen a drop in cerebral palsy, which is great news. And we've definitely seen a drop in severe cerebral palsy. In terms of developmental delay and neurodevelopmental disability, there's no obvious trend of improvements in these particular areas. But if we put all this together and we look at those children who are born extremely preterm, who survive with no major disability, we do see quite a marked, in my mind, increase in the proportion of those children who are surviving without major disability, nearly 20% over this period of time. And so that's really great news, and that is suggesting that with these improvements in care, we are seeing improvements in outcome. But this is outcome to 2 years. And most of you will know, or many of you will know, that 2-year outcomes do not equal long-term outcomes. And so we do need to see whether this corresponds with improvements later in life. Now, a few years earlier, we looked at 8-year outcomes in these same cohorts. The group of interest were the children born in Victoria, extremely preterm in 2005, at 8 years of age. And the domains of interest were IQ, reading, spelling, and maths. And so we wanted to see whether the children born in 2005 were actually doing better than the children born in 91, 92 and children born in 1997 on these different domains. If they were performing better, then these diamonds and 95% confidence interval should be positive to the right of this line, 0. But you can see that these mean group differences, these diamonds, are actually predominantly to the left of 0, negative, which is generally speaking suggesting that the long-term outcome for this particular cohort born in 2005 was doing slightly poorer. Now, that's obviously quite controversial and difficult to interpret, and we don't really know what that means. But what we can say is that we're very confident that at 8 years of age in Victoria, we are not seeing improvement in long-term outcomes in these particular domains. Now, we need to see whether that is consistent when we look at the 2016-2017 cohort when they reach 8 years of age. Now I'm going to move to looking at rate of impairment, because when we're looking at domains such as IQ, motor functioning, educational outcomes, attention, executive function, language, and so forth, what we tend to do is look at mean group differences. Here's one example. Here's a group of children born in Victoria in 1997, extremely preterm at 8 years of age. Here was their IQ, about 93. And that's in contrast to a comparison group of children born full term, very well matched. And you can see they have an IQ of just over 105. And it was basically a 13-point difference. Now, a 13-point difference in IQ is a big difference. That's statistically significant, but also very clinically significant. So it's a big difference, but how do we interpret that? How do we use that to help us in counselling families and talking to families about the prognosis of their child? Well, I don't think it's particularly helpful. Another way is to look at rates of impairment. And using data from this same group of children, what we actually can see is that half the children, 49%, actually have no intellectual impairment. Just over a third of them have mild impairment, so that's an IQ which is between 85 and 70. And there's only 15% of kids who we're probably most concerned about who have an IQ of less than 70, 2 standard deviations below the mean. So I think when we look at mean group differences, it's not really telling us all the stories, and it can actually give us a poorer picture of outcomes than what is really occurring. We can do the same with educational outcomes or any other outcomes. Here's the same group of children born in 1997 in Victoria, extremely preterm here in red, looking at reading, spelling, and maths, and you can see they're performing well below children born full term. And you might expect that based on that, there's a high percentage of these children who are actually got a reading impairment or a spelling impairment and maths impairment. But when you actually look at the figures, the rates actually surprised us. They are much lower than what the mean group differences may have suggested. We see that only 30% of the extremely preterm children have a reading impairment, a maths impairment, and it's actually fewer for spelling, less than 20%. And when we look at the children who we're really concerned about, those children who've got marked problems in reading, spelling, maths, the rates are really low, about 10% or less. So I think when we're looking at the literature and our own data, we need to go well beyond looking at mean group differences, because it can, when we look at the rates of impairment, I think this is information which is helpful for families to understand. They can understand that, okay, yes, there is a chance that their child's going to have an intellectual impairment. There is a chance that their child's going to have an academic difficulty, but there's also actually a really good chance that their child's not going to have a problem in those domains. Whether we look at main group differences or we look at rates of impairments, what we're actually doing is comparing a group of children born very preterm or extremely preterm with another group, a comparison group, which is usually children born full term. And we get a particular story based on those main group differences or rates of impairments. But for those of you who work in follow-up clinics, you'll know that the children who come in at 2, 4, 6, 8, whatever age it is, they're all different and they're all presenting with different difficulties and strengths, and they've got different profiles. So there are now a number of studies which have looked at or done analyses using person-orientated statistics to look at individual profiles, or whether there are subgroups of children who are born very preterm who are exhibiting a specific type of problems. And we've done some research in that area as well. We use a technique called latent profile analysis. And here's one study, the results from one study done by an honours student of mine, which this data is not yet published, but was done some time ago. This was based on a group of children born very preterm. They were seen at 13 years of age. We did a fairly detailed neuropsychological assessment, including domains of IQ, attention, memory, language, and executive function. And then the latent profile analysis identified 4 strong profiles or clusters of children. The biggest group of children was actually this group, the blue group, light blue group here, which represents more than 1/3 of the group. And this is a group of children who are born very preterm, who are performing age appropriately or above in all these domains that we looked at in this paper. The second largest group is this group represented by the red line. And collectively, these two groups represent more than 2/3 of the children born very preterm. This red group is also performing well, generally speaking, with, if you might want to say, selective difficulties in attention and language. So this is a group of children who tend to be doing well, but are having problems in language and attention. Then we have a relatively small group of 30-odd children in green here who are struggling across the board, but are actually got really poor attention problems. And maybe these attention problems are the source, or at least contributing to some of their problems in the other domains, including IQ, memory, language, and executive function. And then we've got a very, very small group of kids, in this case, 10 or so children who are actually performing really poorly across all domains. So children born very preterm are not all alike. They are quite different. And I think this is really important information for you to know for when you're counselling families who have just had a very preterm baby. This is just another example that we've done with using latent profile analysis. This time we've drilled into attention. Attention can be broken up into different subdomains. For example, selective attention, shifting attention, divided attention, and looking at behavioural aspects of attention. And when we just focus on attention, we can see different profiles. In this particular analysis, we found 3 different groups. One group where they're showing good attention, age-appropriate attention. Another group which is showing low average attention, and another group which is showing poor attention, particularly in the area of divided attention, which seems to be an area of concern, particularly for this group of children. So I think in terms of long-term outcome for children born very preterm, it's not controversial. We know that these children have a range of problems, but there is enormous variability. Some children do not exhibit any problems at all. Some children exhibit mild problems, and some children exhibit severe problems. while the nature and profile of the problems also vary. So really the focus of long-term outcome research in my mind, and this is what we focus on and many other groups focus on, is trying to understand the mechanisms for the difficulties that these children have and why some children do really poorly and other children do really well. Some children have attention problems while other children have language problems. Why is that the case? And we've heard some of that story from Dr. Inder just before. Now I'm just going to quickly talk about developmental stability, because many of the outcome clinics around the world follow up children born very preterm to 2 years of age. Some clinics follow children up to 4 or 5 years of age, but very rarely do clinics follow up children beyond that. Now, I know there are cases around the world that do, which is fantastic, but in most cases, children are not followed up for very long at all. So is that a problem? Well, I'm going to argue that it is a problem. In this particular study, we followed up a group of children born very preterm. We saw them at 2 years and 8 years of age, and we categorized their disability as having no disability, mild, moderate, severe at 2 years of age, and the same at 8 years, no disability, mild, moderate, and severe. The children who fall in this diagonal are the children who stay in the same disability category at 2 and 8 years of age. Now that represents less than 50% of the cohort. More than 50% of the cohort actually changed disability categories. If you have a look at the children who had no disability at 2 years of age, there was quite a significant, about 40% of them actually did have a disability at 8 years of age. For the mild disability group, a number of those actually at 8 years of age did not have a disability, while those at 2 who had a moderate to severe disability, they tended to have less severe disability at 8 years of age. So I'm probably not telling you anything new there, that early developmental assessments are not particularly predictive of later assessments. And so if you're assessing a child at 2 years of age and they are delayed, you need to be very careful as to how you pass that information on to families, because within a year or so, they may have caught up and be doing very well. Here's another, some more data showing the same thing. In this study, we've focused on language development, and it's actually the same cohort. We saw children at 2, 5, 7, and 13 years of age where we did an assessment of language. This line up here represents the mean performance on language for the term group, the control group. And you can see that as a group, their performance was very, very stable from 2 to 13 years of age when we utilised age standardised norms. This dotted line represents the very preterm group. And again, you can see that that line, the mean line for the very preterm group, was also very stable across time. And as such, the mean difference between the two groups remain very, very similar across each time point. But when we look at individuals, we don't see that at all. We see marked variability in profiles. We see one group of children who actually performed well at 2 in terms of their language, and that persisted right through to 13 years of age. We've got another group of children here who we called the precocious group, who were doing really well in terms of their language at 2, but then fell away a little bit, and by 7 and 13 years were performing within the age appropriate range, but slightly below. We've got this group of children who were a little bit delayed in terms of their language at 2 years of age, and then quickly caught up by 5 and 7 years of age and performed well thereafter. There was this group here who actually are exhibiting mild language problems from 2, and that persisted right through to 13 years of age. And then we've got this small group of children who started off with quite marked language problems, and that persisted right throughout. So based on an assessment of language at 2 years of age, you can't really have a great deal of confidence as to what their performance is going to be in terms of language by middle to late childhood. And that's the point I want to make. And finally, I want to talk about mental health. Now, we've been focusing on these particular domains, and these are very important domains. These are domains which are critically important for the adaptive functioning for the child. And while, as I've just been talking about, development happens rapidly and their performance can vary from early childhood through to middle childhood, by middle to late childhood, we actually have a pretty good understanding of where each child sits in for each one of these domains. By middle to late childhood, we know whether children have visual and hearing problems. We know whether a child's got cerebral palsy or is clumsy. We know where the child falls in terms of most domains of cognition. And the family and the child knows where they sit in terms of their academic progress. What I think from late childhood into adolescence and into early adulthood, people start worrying about is the individual's happiness and their psychological health. And while we know that behaviour problems can present and emerge very early in life, and many of you have experienced that, really the peak time of a whole range of psychiatric disorders, including anxiety and depression, does come on in adolescence and early adulthood. So I think this is a really important area which has lacked a lot of research, and partly because they're not the major issues which people are focusing on when children are being followed up in early childhood, when these are the focus of those programs. Now, about 10 years ago, Sam Johnson and Neil Marlowe, people who are experts in the area of long-term follow-up, did a review looking at behaviour problems in preterm children, and they identified 3 areas: inattention and hyperactivity, emotional problems, including anxiety and depression, and social interactions. These were the areas of most concern, and they termed it the preterm behavioural phenotype. And there was a thought that this may translate to higher rates of attention deficit hyperactivity disorder, or ADHD, anxiety and mood disorders, and autism spectrum disorder. And the best way of looking at whether clinical populations such as children born very preterm or individuals born very preterm are at increased risk for psychiatric disorders is to do structured psychiatric interviews with them. That gives you very accurate information on the psychiatric diagnosis, enables you to collect a whole lot of risk and resilience factors. The problem is that to do this, it's very difficult. Response rates can be low, and resulting in representativeness, non-representativeness. And also many of these disorders, for example, autism, are low incidence, and so we lack power. So one way of really understanding the rate of psychiatric disorders in very preterm children and adulthood is to do a meta-analysis. And the best form of meta-analysis is an individual participant data meta-analysis, where we pull the data from a whole range of different cohorts. And that's what we did. There's a group of us who collaborate in this collaboration called the Adults Born Preterm International Collaboration. Here are the different groups from around the world who participated in this initiative, and the different authors of this particular paper. And to be included in this analysis, the cohorts had to involve very low birth weight or very preterm children, as well as the comparison group involving a term normal birth weight children or individuals. And they needed to have made a psychiatric diagnosis based on a structured interview utilising DSM or ICD diagnoses. And we were particularly interested in autism, ADHD, anxiety, mood disorder, and disruptive behaviour disorders. We pulled data from 10 cohorts. We had 1 cohort from the US, 1 from Canada, 2 from Australia, 1 from New Zealand, 2 from the UK, 1 from Norway, 1 from Finland, and 1 from Germany. And you can see the numbers varied quite a bit from study to study, as did the selection criteria. and also the age at which they had the interview. The type of interview used also varied across studies, and the psychiatric disorders of interest also varied from study to study. Well, what we found was a marked increase in the very preterm group across a number of different diagnoses. Starting with ADHD, we found that nearly 19% of our group who were born very preterm met eligibility for ADHD, in contrast to about 8.5% of the term controls, which led to an increased odds ratio of around 5.4 or 5.3 when it's adjusted for a whole range of factors. In terms of ASD or autism, there was about 5.5% of the very preterm group met eligibility for autism, in contrast to 0.5% in the control group, which is an increased odds ratio of about 10.5. For anxiety disorder, that was most common disorder across both groups, 16% for the very preterm, 11% for the controls, an odds ratio of about 2. Mood disorder, quite similar, but we still had an increased odds ratio of 1.5 or 1.6 for the very preterm group. We were not expecting an increase in disruptive behaviour disorders based on past research, and that's what we found. There was no difference there. And there was also no difference in terms of eating disorder or psychiatric disorder. In fact, the rates were slightly lower in those born very preterm. So, what are my take-home messages regarding long-term follow-up? Well, as it's pretty clear from all the research which has been done, very preterm survivors, or as a group, are at increased risk for a range of long-term neurodevelopmental challenges. While there seems to be maybe some improvements in short-term outcomes, at the moment there is limited evidence that long-term outcomes are improving with the improvements in medical care and survival rates. Also really want to highlight that there is really significant heterogeneity in the long-term outcomes for these individuals. The vast majority of these individuals do not exhibit major impairments. Many of them have fantastic outcomes. They also differ greatly in terms of the type of problems they have, as well as the severity of problems. Also wanted to highlight that the early assessments of development, such as at 2 years of age, only has moderate agreement with later assessments in childhood and adolescence. So we need to think about that when we're following up these children and giving advice to families. And the mental health of very preterm survivors is a major issue, as I hope I've been able to highlight tonight. Now, going forward, we really need to improve our prediction of who's going to have problems going forward and what type of problems, so that we can more target our surveillance programs and early intervention programs, or as Terrie talks about, neurorehabilitation programs. We also need to be very cautious when we're counselling families, because hopefully you can see that no two children are alike. They show differences in severity of outcomes and different profiles, and also that the type of that problems can change with increasing age. A child can have a delay in something, for example, in language, but by 13 or by 5 years of age, they could have really caught up to their peers. We need ongoing surveillance throughout childhood and into adulthood. While the major domains of sensory, motor, cognitive, and educational outcomes are pretty well known by middle childhood and late childhood, there are other things going on which emerge into adulthood, such as mental health. And I would argue that mental health problems should be a core component of surveillance programs. Right, so I've run slightly over time. Here are the references from the studies I've talked about tonight, and you can get that from my slides. And I just want to acknowledge all the people I've worked with that have helped me with these studies from the Victorian Infant Collaborative Study Group and the Victorian Infant Brain Studies Group. So I'll finish there. Thank you.
Thank you very much, Peter, for this elaborative, very important lecture. And to tell you the truth, this is what we need to follow up our patients and cases. Although it is somehow difficult in the area where the patients are keeping moving between the countries, so you don't have the long-term follow-up for longer than 2 years. I'm having few questions for you here. The first one is, when using Bayley's scale at 2 years, what score do you use for normal, moderate, severe impairment?
Yes, thank you for that question. I mean, the Bayley scales is been the subject of a lot of debate in the literature, mainly because there has been some suggestion that the scores from the Bayley 3 overestimate development, which then results in an underestimation of delay. And now, most places around the world are using the Bayley, have been using the Bayley 3. The Bayley 4 was released about a year ago, and that's got newer norms, and hopefully that those norms are more accurate. So I would be suggesting that people use, if they can have norms which are relevant to their local area, and that may not be the case for a lot of people attending tonight, that they do use those new norms. So the cutoffs we use for delay are those less than 1 standard deviation as being a mild impairment. A moderate severe impairment would be anything less than 2 standard deviations below the mean. We in Australia do have Australian norms, which is helpful, but that's relatively new. Before that, we tended to use control groups to help us in making those cutoffs.
Thank you. There is another question. How early the assessment need to be done?
Well, I think it's really a practical issue. I know many of these babies are going through follow-up programs from very early in life. And I think that's really important because the best way to work out whether a child is developmentally delayed or whether the child actually has an ongoing impairment is to see them regularly and to monitor their development. So many groups use their main follow-up time point as 18 months, and many use 24 months. Our recommendation would be 24 months because we've published literature to show that 24 months is more predictive of long-term outcome than 18 months. Neither is fantastic, but 24 months is better than 18 months. But I think you shouldn't just wait to 24 months. By the time a baby's at 24 months and is exhibiting problems, then it's often, you've often missed the gate. You can start a whole range of interventions well before that if the child is having problems. So depending upon the centre that you're working in, I would be suggesting very frequent assessments in the first year of life and then a major neurodevelopmental assessment at 24 months.
Thank you very much. One last question here till now. What is the relation between prematurity and math disability?
Yes, well, of all the academic difficulties that children born very preterm have, the area of mathematics is is the area which is of most concern. I have a PhD student is looking at that at the moment, and the rates are pretty high in this group of children. We're really not sure whether that's due to difficulties with processing speed, working memory, whether it's a problem with executive function. So these are all things that our group and many others are trying to sort out, but there are clearly a number of factors which are contributing to their problems in maths problems. But in saying that, as I've tried to highlight today, not all children born very preterm have maths problems. A lot of them don't. But it is an area of concern, definitely.
Okay, thank you. There is a question popped up now. Could you comment on the socioeconomic status estimation for those cohort studies in association to the cultural difference among countries?
Yes, I think that's a very important point, and I think that when you are looking at the long-term outcome literature, you do have to look very carefully at where the study is being undertaken and the different health systems and the socioeconomic characteristics. In Australia, we have a universal medical system, and we don't probably have the level of poverty that many other countries have, including the US. So we do not necessarily see a huge percentage of children born into very disadvantaged families. Of course, we do have some of those children, but we don't have this significant proportion that other countries may have. So I think that you will see differences from country to country. There have been studies which have shown differences within countries, from regions within different regions within countries. So I think long-term outcomes can vary from country to country, and I think they can even vary from within countries. So I think that they're factors that need to be considered. Some of them are going to be socio-demographic characteristics, and some of them are going to be clinical characteristics.
Thank you very much, Peter, and thank you for being with us till 1 a.m. at your country. And by this, we can conclude the session. And I hand over to the next moderator. Thank you very much.
Thank you.
Thank you, Dr. Khalid and Dr. Anderson. I'm Dr. Rajesh Sharma, neonatal consultant at Cornish Hospital, and I would like to welcome the next moderator, Dr. Amar, who is working as a consultant pediatrician and neonatologist at Amina Hospital in Ajman. He's got an extensive experience in pediatrics and neonatology, working in various countries like UAE, Egypt, and Saudi Arabia. So I would hand over to Dr. Amr for moderating the next session. Dr. Amr?
Thank you, Dr. Rajesh Sharma. I'm very happy and proud to be with all of you, my seniors and my colleague friends today. I'm very honored and thanks for my scientific committee and Dr. Monica for invitation. I'm Dr. Amr Ismail, Amina Hospital pediatrician and neonatologist and clinical researcher. I'm happy today to introduce our next expert, Dr. Adam Kirton. Dr. Adam Kirton is the professor of pediatrics, radiology, and clinical neurosciences at the University of Calgary, Canada, and an attending pediatric neurologist at the Alberta Children's Hospital. He holds the Dr. Robert Haslam Chair in Pediatric Neurology and serves as the Deputy Head Research for the Department of Pediatrics Dr. Kirton's research focuses on applying technologies, including neuroimaging, non-invasive brain stimulation, and brain-computer interfaces to measure and modulate the response of the developing brain to early injury to generate new therapies and opportunities for life participation for disabled children. He served as the inaugural board chair and vice president of the International Pediatric Stroke Organization, the International Pediatric Stroke.org. Dr. Kirton directs the Calgary Pediatric Stroke Program, Alberta Perinatal Stroke Project, the University of Calgary Non-Invasive Neurostimulation Network, and the ACH Brain Computer Interface Laboratory. Let's welcome Dr. Adam Kirton. Hello, sir.
Hello, thank you very much. Thank you for the introduction and the invitation. And good morning, good afternoon, good evening to everyone. And I hope you can see my first slide. If you just give me a thumbs up there, Hammer. See my slide?
Yes, we can.
Yes, okay, great. Okay, so I'm going to take about 30 minutes and try and provide you with a clinically relevant, practical overview of where things are at currently in the world of perinatal stroke. This is an area of great interest to mine. Many other experts on this symposium who have relevant expertise and will be sharing relevant knowledge with you, I know. So I'm trying to fit in the gaps in between those. I don't have any disclosures. I will tell you at the beginning about some of the young patients that I follow with perinatal stroke. These are two, Alana and Mike, who've been a big part of our program here. Just to set the stage that all I'm going to talk about is really from the point of view of the patient. What can we do in a baby with a stroke from day one and all the way through to, these two are now young adults, all the way through to adulthood to optimize outcome. And I'm going to focus on the neonatal period because I think that's where a lot of this audience is coming from. And if there's time at the end, I'll touch a bit more about the long-term outcomes and what we can do later on. So the main learning objectives are really to get comfortable with recognizing stroke in the newborn. I'll have you learn about the 3 common acute neonatal stroke syndromes, how to diagnose them and manage them. And the management is really about objective 2. That is, what can you do in the first hours and days to optimize outcome by protecting the brain from further injury? That's really where the early intervention is focused. And then what else can we do beyond that to improve outcomes? So I'll give you quite a few references along the way. Please jot them down, and I think you'll have copies for the of my slides. Try to give you links to what I think are some of the best review articles and general resources. This is one that I like, and it's written by Mary Dunbar, who was a fellow with us. It will go over a lot of what I'm going to tell you. And the main point here is that perinatal stroke is not just one disease. It's a group of very recognizable and quite easy to define diseases. What they share in common is that they're all focal vascular brain injuries. When you break it down from there, all you have to consider is what kind of blood vessel. Is it an artery or a vein? Is the blood vessel blocked? That's ischemia. Or does it rupture? That's hemorrhage. And when does this happen and when does it present? And if you think about those variables, you can define these now perinatal stroke syndromes or what are really specific perinatal stroke diseases. And that's what's shown in the bottom panel here. I hope you can see my cursor. We're going to focus over here on the acute symptomatic strokes. There are some that occur in utero or are not recognized in the newborn. They present a bit later. But in the newborn, there's really 3 main types. And the textbook type, the most common that most people are familiar with, is an arterial ischemic stroke, blockage of an artery. We'll talk about that first. But we also see sinovenous thrombosis, and we also see hemorrhage. And we'll go through each of those 3. They have a lot in common, but also a few distinct differences about how to recognize and manage them. So we'll start with that, and then we'll come to the common themes in objective 2. That is, how do you protect the brain after it's had a focal vascular injury? So how common is perinatal stroke? I think more common than we used to think. And this is a nice paper, again, from Mary Dunbar in our province. This is Canada. I know we're talking to people all over the world. This is our province, Alberta, here in Western Canada. And we're very lucky here because we can do population-based research in our provincial healthcare system. And so Mary did a great study that I think has really pinned down by each of those specific diseases I just showed you what the most likely birth prevalence is. And if you add them all together, it's almost 1 in 1,000 live births. So actually a pretty common problem, arterial ischemic stroke being the most common. And if you're more interested in the epidemiology, please take a look at that paper. So arterial ischemic stroke is really the most common and recognizable. This is a typical story. This is the MRI of a 1-day-old baby, normal mom, normal delivery, normal pregnancy. And the baby has a seizure on day 1 and goes to the MRI. And here's a diffusion weighted MRI where bright is bad. And you're seeing a huge stroke. The entire left middle cerebral artery has infarcted sometime in the last few days. And you can see also the rest of this very otherwise completely healthy and normal brain. That becomes very important for determining outcome. And when we get to objective 2, I want you to think about all this healthy gray brain right beside the stroke. You can see this stroke really took out the whole middle cerebral artery. But what if we could have saved some of these neurons that were on the edge, that were, had a chance to survive, but they were unable to following this injury? That'll be an important thing to consider. But we see cases like this regularly. Arterial ischemic stroke is the most common form of acute neonatal or perinatal stroke. And I'll just try to summarize where I think the evidence is at. If you look at the big picture, like I did here, this was from our International Pediatric Stroke Study. Here's babies from all over the world who've had neonatal strokes. This is an uncontrolled descriptive study from this great registry based at the Hospital for Sick Children in Toronto. 250 cases is a good sample. And there's some general themes that start to come out just when you look at a large sample like this, that the babies are sometimes sick. In fact, most of them actually look pretty good, but they can mimic babies with other conditions. They can have encephalopathy, difficult transitions. The moms are usually healthy and, as I said, unremarkable pregnancies. And a few other patterns start to come out. You notice that there's often more than one stroke, often in the other hemisphere. That gives you a hint about where the blood clot came from, and I'll come to that. And when you look for specific causes like congenital heart disease, which is a cause, it actually only accounts for a small percentage. And a lot of these strokes, it's very hard to understand exactly why it happened. And I'll go over that in a minute. Treatment is really limited to neuroprotection. And when we looked across the world, the use of antithrombotic or other specific medications is very uncommon. So what causes a baby close to delivery to have a clot stick in the middle cerebral artery? We know that's the mechanism, that's what a stroke is, but why would that ever happen? And what I'm showing on the right here is a list of references if you're interested. There's about a half a dozen very well done case control studies from all over the world that have tried to look at clinical variables that might predict a neonatal stroke. And they're very good studies, but the disappointing part is there's almost never a real smoking gun. There's never a really clear clinical picture or setup for neonatal stroke. It's very hard to predict. And so looking at all those factors doesn't really help tell you a lot about why it actually happened. And you can imagine all those things we think about when we take a neonatal history in the NICU and you ask all those same questions, but rarely does it give you a specific answer. Sometimes you'll find a complex congenital heart disease. You might find an infection like bacterial meningitis that can definitely cause a stroke. But these are a minority of cases. And when you look at all the other variables, you rarely find something. And this fits with an evolving model in the field that suggests the placenta as a source of embolism is probably responsible for many of these cases. And so if you just remember your fetal circulation, any problem in the placenta, but imagine an inflammatory condition like chorioamnionitis or a thrombotic condition, something leading to clots forming on the venous or on the fetal side of the placenta, so that when it enters the baby circulation, of course, it bypasses to the left side of the heart. Most of the blood's going up to the brain, and it will cause an embolic stroke, block the middle cerebral artery. Or if you're unlucky, there'll be more than one clot, it'll block 2 arteries, which quite often occurs. So this tells you there's a proximal embolic source. When you see strokes on both sides of the brain, if the heart is normal, where else can the clot come from? Before birth, the placenta is a very suspicious candidate. It's very hard to prove though, because the placenta is usually not obtained. As I mentioned, the baby often looks well. So can we ever get more specific than that? This is a study, and the details here aren't important. What it's showing is that if you look using a baby's blood spot at their inflammatory profile, let's call it, their milieu of inflammatory cytokines in the blood. This is a study by Alex Maneko in our group. You actually see some quite surprisingly specific patterns that differentiate the different conditions, which are these colored blobs here. These are arterial ischemic strokes compared to another type of arterial stroke, compared to venous strokes, which we'll talk about in a minute, compared to healthy controls. There are differences in this baby's inflammatory state. That's very interesting. Could it ever lead to a prevention strategy where we could identify at-risk pregnancies? Much more difficult. One thing that people always ask is this about blood clotting disorders? And we can't say for sure that disordered coagulation right at the time of stroke may be a factor for some children. However, in this study, when you look at, in a controlled way, look at a large number of children who are a year of age or older, to answer the question, do these children carry inherent thrombophilic disorders through their life? You find actually very little. There's some conflicting evidence here, but in this large study, we found actually virtually zero association with chronic thrombophilic conditions. So it doesn't mean you shouldn't think about it when you see a baby with a stroke, but in terms of long-term testing, the need to test children who've had neonatal or perinatal stroke appears to be limited. In fact, we don't test, and many centers are now not testing, unless you have another reason, a strong family history perhaps. So this is a recent change in practice over the last few years at many places. And lastly, don't worry, you're not supposed to read this slide. The point it's trying to make is that the interaction between factors in neonatal stroke is complicated. And so there are so many factors to think about, different types of stroke, thinking about the mom, the baby, the interaction over time. This is what complicates developing a model to explain why, in this case, arterial ischemic strokes might happen. Will we ever have a test or a specific answer where we can predict neonatal stroke? I'd like to think so, but to be honest, I think that may not be realistic. Okay, so that's a brief view of arterial ischemic stroke. Here's another baby, but almost the same story. Term baby, normal mom, normal pregnancy, delivery, and this time a few days into life, let's say day 6, presents with seizures. And I know we don't do a lot of CAT scans anymore, but sometimes we do. And this was done at an outside center. And this CAT scan looks almost normal, but there's a little hyperdensity here. I hope you can see my arrow just under the left lateral ventricle. That doesn't look like much, but it actually means a lot. So I'm going to show you a particular case of CSVT, very important. Sometimes it's easy to diagnose. There's huge clots everywhere. But in this baby, on the CT scan, all you see was this little hyperdensity, and there's one in the left frontal lobe. And if you remember your venous anatomy and drainage, you'd be like, uh-oh, these both drain through the central deep venous system. So you go and do an MRI and you find some soft diffusion changes in the same area. You find some little T1 hits throughout the deep venous territory in the left. You look closely on the T1 MRI, there's something bright in the straight sinus. And you do an MR venogram and there's no flow in the straight sinus. This is a big, big problem. And if you're lucky and your MRI can do fancy hemorrhage sensitive imaging, you do something like this susceptibility weighted scan. And in those same areas, in the groove here and up into the frontal lobe, you see this backup and congestion of blood. All of these signs point to deep sinovenous thrombosis. Now, don't worry, I know this is hard to see. I'm showing it because this is a hard case to pick up. It can be much more straightforward. So this is neonatal sinovenous thrombosis, the second type of acute stroke. And to recognize this, you really have to know your venous anatomy. So you have to remember how the brain drains its blood through superficial and deep systems into a common system, and think about where that blood has to drain. And so if a clot blocks up that drainage, which areas of the brain are going to suffer? Which areas of the brain are going to get congested, infarct, and sometimes hemorrhage into themselves? This is often the story of sinovenous thrombosis. And here's another one just to make the point, another one, end of the first week of life, a neonate with posturing and seizure, another CT scan, and all you see here is blood. So your first thought is hemorrhage, hemorrhage, hemorrhage. We'll come to hemorrhage in a minute. But if you have to look really closely, you'll notice that there's actually blood in the thalamus here. There's blood in the brain that has spilled out into the ventricles. And this is a warning sign for deep sinovenous thrombosis, so a clot in the straight sinus. And if you do an MRI and you look closely at the patterns, you see some very distinctive things. You see these little strands of diffusion imaging all the way out in the frontal lobes. And if you flip over to the right here, the hemorrhage imaging, look at these little strands. Linda DeVries, who you'll hear from today, calls this the iris sign because it looks like a flower. And these are the deep veins of the frontal lobe. They drain all the way back into the middle of the brain. And in the middle here, you see little scattered diffusion hits also in the same venous territory. So it's a very messy pattern. All you really see is hemorrhage at first. So you really have to look closely and think about deep CSVT. You do an MR venogram and there's supposed to be a straight sinus here in the middle and it's not there. That gives it away. Now you know what you're dealing with. Okay, and it's potentially treatable. This is not a new understanding. Yvonne Wu published this very nice paper now almost 20 years ago, showing that when you see intraventricular hemorrhage in a term baby, of course it's different in a preterm baby, your first thought should be deep sinovenous thrombosis. They don't have a germinal matrix anymore. This is not germinal matrix hemorrhage. And there's a big clot here in the straight sinus. There's a hemorrhage in the thalamus. This is a life-threatening problem and it's potentially treatable. So very important to consider. Still, the best information is Gabrielle de Weber's seminal paper. It was in the New England Journal also about 20 years ago, describing a large cohort of neonates with sinovenous thrombosis. The point is that the presentation is non-specific. It's neonatal encephalopathy of some variety usually, so you can't rule it out or in clinically. So just keep it on your list of suspicion. And the risk factors, there's still never been a controlled risk factor study for this condition, but there are a few obvious things like babies who are very sick, septic, meningitis, those are risk factors for sure. Possibly dehydration, maybe even due to poor feeding. This may be why a lot of babies don't present right at birth. They present more like the first week of life. They've gone home, not fed well, become dehydrated. Whether thrombophilia plays a role, it certainly could. So another thing to consider. So these are some of the potential risk factors. And I'm going to talk about treatment about stroke in general in a minute, but to make the point about specific to sinovenous thrombosis, anticoagulation is a very reasonable treatment to consider. This is still the best study I'm aware of from Mahendra Movarir at Sick Kids, a large group of kids with CSVT, including neonates, treated with heparin or an anticoagulant. And there appeared to be much less propagation of thrombus in babies who were treated and a very good safety profile. So anticoagulation should definitely be considered. This is a snapshot of what was going on around the world several years ago. This is Laurie Jordan's paper from the IPSS. And the patterns of treatment vary widely across the world. About half of babies, this is about 10 years ago, half of babies were getting anticoagulated. I think this number has been gradually increasing as people become more comfortable. You may need the help of a thrombosis expert or hematologist to get comfortable with this, but it's definitely should be considered. Okay, the last type of acute neonatal stroke is this. It's usually the same story. It's a term baby, looks well, and starts seizing. And that was the story with this baby. But this time when you do the MRI, instead of ischemia, you find a huge hemorrhage in the right frontal lobe, black as blood on this T2 weighted sequence. Here's another baby I follow who presented and crashed, almost died immediately after birth. This is a hemorrhage sequence, and I hope you can appreciate it. There's a huge hemorrhage in the posterior fossa here, squishing the brainstem. So hemorrhage is a major life-threatening condition in the newborn that needs to be considered. So this is our third type of acute symptomatic neonatal stroke. The levels of evidence here, I'm afraid, are even lower. Historically, they're really limited to case series from single centers, uncontrolled, non-population-based studies. They have interesting information, but they often use inconsistent classification. They're a bit hard to interpret. Imaging is very helpful for hemorrhage, and I'll just show some examples here. Of course, the ultrasound, CAT scans, and modern MRI can really break down individual ages and types of blood in the brain. So we use these together. MRI, of course, is probably your investigation of choice for the best information. It's important with hemorrhage to keep in mind that some hemorrhage is normal. So a little bit of blood outside the brain, subdural, subarachnoid hemorrhage, is common depending on which study of normal newborns you read. It could be as high as 30 or 40%. It's usually modest in volume and not a huge hemorrhage, not pushing on the brain, not doing any harm. But sometimes people see a scan and reports hemorrhage, and everybody gets very excited and says, oh my God, there's a hemorrhage. Remember that a bit of subdural subarachnoid hemorrhage is normal. So what hemorrhages do you worry about? Well, this is one way to classify hemorrhage. This was a paper that we published a few years ago. And I'll draw your attention to these MRIs at the bottom here. So here's the first MRI I showed you. We call this neonatal hemorrhagic stroke. This is a single hematoma in the brain parenchyma. It turns out to be the most common type, but it's only about 2/3 of cases. The other third are made up of diseases we already have talked about, or you know, that is arterial strokes, venous strokes, and global hypoxic injuries that tend to bleed into themselves as the injury evolves. So you can see this is in a stroke, this is a deep CSVT. That's called hemorrhagic transformation. That's what HT means. So if you see blood in the brain on an MRI, think, is this primary blood? Did it just bleed, or is it blood oozing into maybe an ischemic or another type of injury? Have to consider both possibilities. What causes hemorrhagic stroke? Also often hard to say. Babies are often sick with other things. It seems to be more common in congenital heart disease for a variety of reasons. But when you look at these isolated hemorrhages in the brain with no other explanation, you look for things like bleeding diatheses or vascular malformations like an AVM. But in this large study, which was almost 100 newborns, you can see that's only accounting for like 15, 20% of cases. And so you don't often find a specific cause for a big hemorrhage like this, which is very frustrating. And it often leads people, when they see blood, to think trauma. I see blood, trauma causes blood, this must be birth trauma, quote unquote. And that can be a mistake. And so in this study where we carefully define trauma, it occurred, but it was actually very rare. So does trauma cause neonatal hemorrhagic stroke? If you look back at those historical studies, most of them never even actually looked at trauma or certainly had no systematic way of evaluating for it. I'm going to skip that. This is a paper we have that it will hopefully be published soon. It's just under review. We used MRI to actually quantify trauma to the baby's head using the outside of their head in a large series of babies with HIE and stroke, including arterial and hemorrhagic stroke. And the take-home message is there was zero association between the amount of trauma imparted and any of these types of brain injury. That may come as a bit of a surprise, but it means that at the very least, we need to be very careful about how we use the word trauma and how we consider it as a cause for stroke of any kind, especially hemorrhage, which is where it usually people put it at the top of the differential diagnosis. I think it should probably be at the bottom. So why would a baby just have a stroke suddenly at the time of birth, a big hemorrhage, a rupture of a blood vessel? Honestly, we don't know. This is some research we've done about how twisty your arteries are and how perhaps that implies how they're built congenitally. And interestingly, in a large series, we found that babies with neonatal hemorrhagic stroke have a much wider range of twistiness of their arteries. Is that a sign that their arteries are just a little different and prone to rupturing? This is just a theory that remains to be proven. Okay, the last, I'm just going to finish with a bit on neuroprotection. I want to make sure I don't go over time. I'll skip over this venous stroke. So what are our strategies for neuroprotection once we make this diagnosis? Well, here's a case that really highlights the issue. Here's a baby on day 1, has a left MCA stroke, just like I showed you in our first case. And we don't usually do another MRI, but for whatever reason, this baby had one done 4 days later. And look what happened to the stroke. So it was pretty significant on day 1, but by day 5, it has filled out. Look at the temporal lobe here. It's completely infarcted, even though it looked like it was going to hang on and survive on day 1. So this is the evolution of brain injury. We know it occurs in HIE, and we know it occurs in stroke. It occurs over many days, maybe longer. And there's I still cite this great article from Donna Ferrero in the New England Journal about the time course of neonatal brain injury and how protracted it is, which the good news is, does it give us a window to do something to improve outcome? So neuroprotection, for the most part, means thinking about keeping whatever brain is on the edge of dying and trying to keep it healthy to let it survive. So how can we do that? Attention to seizures, which I'll talk about, normothermia, normal glycemia, normal blood pressure, oxygenation, perfusion. These are all things it's easy for the neurologist to write in their consult. Sometimes it's a much bigger challenge for the neonatologist to achieve in the unit. But these are the basic principles of neuroprotection that come from animal studies, adult stroke, and other areas. Okay, so we all know these things, but it's important to practice them. Think about them when you see a baby with a fresh brain injury. So what about seizures? Well, do seizures make brain injury worse? We're not going to go there today. I'm not anyway, maybe Renee will. I think of great papers like this one to suggest they do. It certainly guides what most of us do in the NICU. But what about stroke specifically, and how aggressive should we be? So I'm certainly going to tell you just to treat seizures like you normally would according to best practices. But is there any drug specific for stroke? Of course not. We don't have any evidence. So we follow the same general rules for neonatal seizures. How long should we treat is a tougher question. And this study from Renee and Hannah and others showed a few years ago that the stroke patients, when they go home, are among the most likely to stay on anticonvulsants for the long term. They were some of the highest. This is probably not necessary. In fact, we've taken babies off now for many years. So don't be afraid of stopping anti-seizure medicine early in babies with stroke. And to back that up, thankfully, thanks to Hannah and Renee and others, this is one of my favorite papers from last year that really addressed the question that we'd all been asking for many years. Do you need to leave a baby on anticonvulsants, anti-seizure medicine, sorry, when they go home? The answer we've often thought for stroke is no. Their study would definitely support that. I'm sorry, I won't, Renee maybe hopefully will mention it later today. The point here is that if you take a baby off before they go home, the outcomes look very similar, and the risk of early seizure recurrence is very, very low. So very safe to stop, and maybe not good to leave them on a drug through early development. They've just had a brain injury. Lots of evidence continues to emerge. It's been there for decades that some of these seizure drugs are probably not great for brain development. So you have to have a good reason to leave a baby on seizure medicine, in my opinion. Stroke does not appear to be a good reason. In fact, you're very safe to stop medication. This would be one of my key take-home points today. You should seriously consider stopping all seizure medicine in babies with stroke before they go home. Okay, what else could we do? There's a few conservative things. In babies with sinovenous thrombosis, we had shown in a study years ago that their superior sagittal sinus may be compressed if you lay them on their back by the occipital bone. Lots of babies do this. So simple nursing techniques to make sure the baby has good venous drainage. Don't lie them straight on their back supine. You might actually help their venous drainage. Pretty simple, but probably works. What about true neuroprotection? In the past, that was never an option, but thanks to leaders at Utrecht, Manon Venders and Linda de Vries and others, there is a neuroprotection trial now underway, which we're very proud to be enrolling in Canada. This was our first patient. This sweet little girl had a large MCA stroke. This is a randomized trial of erythropoietin, which many would know is under investigation for other forms of injury. The trial is ongoing. We don't know the results yet, but an exciting time where we can use imaging, predict risk, and intervene in the first days of life to try to save brain cells. A very exciting opportunity that we've never had before. And will that come with other things? These are emerging trials in adult stroke and others with exciting neuroprotective drugs that may come to our world of neonatal stroke. But not yet. So I'm almost out of time. I just have a few minutes left, so I'm going to skip forward to the end and give you a summary. Here it is. So to take home everything I've tried to tell you today, this is a review article that Ritika, who's a fellow just finishing with us, we wrote. It's just published last year in Neo Reviews. This flow diagram is, it is not a protocol. It's not telling you what to do, but it's some general considerations for a baby with a stroke, an acute stroke. And what it tries to do is tell you, of course, think about stroke, choose your imaging wisely, and then make the diagnosis. Is this an arterial stroke, sinovenous thrombosis, or a hemorrhage? All of them need neuroprotective care, and outline some of the basic principles there. Then think about that specific disease that I'm looking at. This is arterial. Am I sure the heart's okay? I should do an echocardiogram, see if I can get the placenta for pathology, make sure it's not meningitis. Rarely are you going to anticoagulate, and you usually don't need to re-image them. If it's a placental embolism, it's never going to happen again, right? The recurrence risk is almost zero. If it's a sinovenous thrombosis, same thing, exclude meningitis, but very quickly consider anticoagulation. Those babies you will need to re-image to see what the clot's doing and see if it's gone away. Hemorrhage, acute care, very important, can be life-threatening. Think your tests change a little bit. Think, I wonder if this baby has a bleeding disorder. So you would do a few extra tests there. Maybe you need neurosurgery's opinion. And you may need some more imaging to make sure the hemorrhage isn't changing or growing. Okay, so just some really practical approaches. And then when you want to get fancy, you can think about prothrombotic tests, genetic tests, bleeding disorders. These apply across the group, but they're sort of your second line. You start consulting the experts to help you. And the last point is about education. This is everything we can do before the baby leaves the NICU. And I'm going to finish with that point and show you one slide. Okay, and then of course we're going to follow them up. Okay, and so what can we really do to improve outcomes? The outcomes are not great. Most children suffer lifelong morbidity. Motor disorders, cerebral palsy is the most common. So that's hemiparetic cerebral palsy. And that's where most of the research is focused. It's where a lot of our program focuses that I won't have time to share with you today, but there's some examples in my slides if you're interested. Only about 30%, these are the arterial kids, end up with big problems outside of the motor system, learning, cognition, behavior, language. That's a big number, although it's amazing that 2/3 of the kids actually are otherwise usually normal. They do really well, which is amazing. And so we think about these outcomes. I'm going to skip through my few slides about how we measure and map the brain to understand their outcomes, and brain stimulation and other treatments that we try to help kids to function better. And I'm going to leave you with one last slide, this one. So anybody who sees babies in the NICU who have any kind of brain injury, but I'll make the point here for stroke, need to address the mental health of the parents, in my opinion, right from day one. And I know that all the good clinicians on this call do this, but I think we're learning some of the details that can really help us to improve long-term outcomes. And so for stroke specifically, we've spent time with our families. We follow over 1,000 families in our province here, and they've been great partners in research, and we've been learning from them about what it's like to have a baby have a stroke at birth. And the overwhelming finding is that the psychological morbidity that comes with that can be substantial. And we're starting to understand it with the help of psychologists. Taryn did her PhD with us and has developed this measure if you're really interested in studying this in stroke specifically. But what comes out is that misplaced feelings of maternal guilt are the most common if they are not assuaged by you as the caring clinician. We often can't tell them exactly why a stroke happened, and the birth was not what they expected, and they read on the internet that I should have done this and I shouldn't have done that, and now my baby has a stroke and I must have done something wrong. In my opinion, the single most important thing you can do as a clinician is to take, sometimes it's 10 minutes, sometimes it's an hour, sometimes it's more, to talk that through with parents repeatedly from day one. And I still do it in the clinic years later because sometimes the issues are still there. A resource we developed is a whiteboard video. It's about 5 minutes long. It's on our website for free. I'll give you the website link on the next slide. And we think it is really helpful. We're just finishing a study with Laura Lehman at Boston Children's to look at how effective this might be and understand other adverse outcomes like PTSD. But we're sure it's an issue. And I think tools like this can be very helpful. So please take a look and feel free to use it in your practice. And lean on community-based support organizations. Here in Canada, it's the Heart and Stroke Foundation. They can also be very important in providing peer and parent support groups. So I'll finish there, and in summary, say that perinatal stroke definitely is a leading cause of lifelong disability that presents in the newborn. And I think by considering elements of neuroprotection and the whole care of the patient and family, we can optimize outcomes, and we'll continue to strive to do so. The reason to do it is the outcomes. As I said, some of these kids are amazing. Mike and Alana, who I showed you on the first slide, have both become Paralympians. They've won medals for Canada. They are high performance athletes. They're both also successful young adults now. Mike's in business school. And so these kids can accomplish big things. They're the outliers. They're enormously successful. Peyton, who had strokes on both sides of her brain and is quadriplegic, is also accomplishing things. So never underestimate the power of the developing brain. Here's those references. Our website, perinatalstroke.ca. I encourage you to engage with the International Pediatric Stroke Organization. We have an upcoming inaugural conference. And thank you very much to my team and funding here and for the invitation. Thank you.
Thank you, Dr. Kirton, for the great talk. Very informative, well organized, well illustrated and imaging. Thank you so much. And some questions here, if you please, you can answer for this. In your opinion, what is the best neuroimaging modality for a stroke?
Yes, thank you. Yeah, good question. The short answer I would say is the MRI is the diagnostic modality of choice. It gives you by far the most information, arterial, venous imaging, hemorrhage, understanding hemorrhages. It gives you all of that. Having said that, there are good reasons to use other tools. Ultrasound for its ready availability. Sometimes CAT scans, if MRI is not available, can also be very effective. So I think you have to judge on the clinical circumstance. What do I need to know and when do I need to know it? If it's a well-looking baby who just had a seizure, but you don't know why, you don't have a good story for HIE, for example, they should go in the MRI soon. That would be my advice. And that's what we're lucky to be able to do at our center. But not every center can provide that ready access to MRI. So know the tools and use the ones available to you in this, as the circumstances dictate.
And for babies with the CVST and the coexisting hemorrhage, is there a volume of hemorrhage that would be a contraindication to the anticoagulation therapy, or even if there is hemorrhage, anticoagulation is still the best step?
Right, very good question, and probably the most common question asked in this population. So there's no good evidence. There's still no randomized trials, of course. The safety data for anticoagulation, which I cited, is overall very good based on hundreds and hundreds of babies in the literature, many of whom, a high proportion of whom, had some degree of hemorrhage. And in the adult CSVT world, hemorrhage is no longer considered a contraindication. And it's very hard to prescribe heparin in a baby whose head is full of blood. I understand it's very, that makes everybody nauseous when you think about doing it. The adult CSVT evidence shows that it's very safe. What's much worse is for the clot to propagate and cause more infarction. The chances that anticoagulation makes your hemorrhage grow appears to be, nobody can say it's zero, but it appears to be very small. The neonatal data is much less than that, but is substantial and suggests a very good safety profile. So many would consider it a relative contraindication. So if you have signs of active bleeding, an enormous hemorrhage, increased intracranial pressure, zero ability to tolerate a bit of extension of a hematoma, those would all be good reasons not to do it. But some blood alone is not an absolute contraindication. I'm sorry, that's a soft answer, but that's the evidence is soft. So I'm trying to fit it to that.
Thanks for your answer. And how late can you start the anticoagulation therapy and the sinoprody thrombi in a neonate, and what is the regimen for this therapy?
Thank you, and I'm really glad you asked because I forgot to make a really important point on that treatment slide. The study I cited from Sick Kids, what it showed was that if you choose not to anticoagulate, you may have a good reason, that's okay. But their studies showed that about 30% of babies, if you don't treat them, the thrombus will propagate and grow in the first, they had a standardized protocol then, 5 to 7 days. So the most important thing is if you choose not to anticoagulate, make sure you re-image. Of course, if the baby gets worse, re-image them right away. But if the baby's stable, you should still re-image in 5 to 7 days to make sure the clot hasn't grown. And if it's growing, then you should definitely consider anticoagulation. There's no specific number about the number of days. You need to convince yourself the clot is getting better and not worse to make your treatment decision.
And you have often seen hypoxic ischemic encephalopathy and stroke together? Sorry.
Yes, sorry, good question. Yes, they can definitely co-occur. So, and this is where the imaging helps you. You need to look for both at the same time. It really fits with the placental hypothesis in that, sorry, my dog. If the placenta is sick, it puts the baby at risk of both HIE and stroke. Any other questions?
Okay, and when you consider weaning the anti-seizures in a patient with a stroke and focal neonatal seizures, if no occurrence after initial seizure?
Yes, thank you. So regardless of the semiology of the seizures, you said focal, but as we know, seizures can look like just about anything, or we may not see anything clinical. Once you've attributed neonatal seizures to a stroke, The seizures almost always settle down within the first days and the first week, usually by the time of discharge. And so the evidence that I cited, Hannah Glass's paper, is very consistent with our findings and our practice here of discontinuing anti-seizure medicine at discharge. We've done that consecutively on over 100 cases of neonatal stroke. And I've only seen one child have a possible seizure a few weeks later and come back to care. And that's not wasn't a bad outcome. It was a brief possible seizure. 99% of the children we've done that with have not returned. They can develop epilepsy for sure many years later. The risk is about 25, 30%, but rarely does that happen in the first months of life. And so to leave a child, the message, just to reiterate it there, historically, the way I was taught was, well, this baby's had a bad brain injury. They're clearly having seizures. They need anti-seizure medicine. That was very logical. And we would leave them on for 3 months, 6 months, 12 months, and they wouldn't have any seizures. And we'd say, oh, aren't we good neurologists? Look at it, my phenobarb is working. And I think it only took some careful consideration to realize that maybe that's just the natural history of acute seizures in neonatal stroke. The phenobarb was probably doing nothing in the vast majority of cases and is potentially not good for development. So I hope that answers the question, but just to reiterate the point that I'm not aware of any reason to continue a baby on anti-seizure medicine at discharge in the case of an otherwise straightforward neonatal stroke.
You prescribe aspirin for baby with ischemic arterial stroke?
I'm sorry, there were two of you there. I didn't catch the question.
Do you prescribe aspirin for baby with ischemic arterial stroke?
No, good question. So for arterial stroke, remember the recurrence risk is almost zero. If it's a placental embolism, the risk factor is definitively removed. The rare case of complex congenital heart disease, so I've mentioned it briefly, but a baby with an arterial stroke should have a careful cardiac exam, and most places will do an echocardiogram. The yield is low if the baby looks normal. But if you prove congenital heart disease, or perhaps I've seen a few cases of a thrombus still floating in the heart, that's obviously high risk for recurrence. If you have an intracardiac thrombus, most would consider anticoagulation, not aspirin. And so there are no clear indications for aspirin therapy alone. I'll make the point too, there's also no indication for emergency treatment. Sometimes people ask, as most people know, thrombolysis and EVT have revolutionized adult stroke. Remember that we're diagnosing this stroke probably several days after it happened, even if you're prompt, even if it's day one. So the idea that you could do EVT to save brain in neonatal stroke is not realistic. I mention it because there's a case report just published a few months ago. We wrote a letter to the editor suggesting that you could, and they were claiming that it had helped, and that it was really not an accurate report. So both emergency recanalization therapy like thrombolysis, as well as aspirin are generally not indicated. Anticoagulation for the rare circumstance of cardiac thrombus.
Because many questions are there, but the last question, because the time is done. Do you routinely perform brain imaging to the first day seizure of newborn, or how do you predict first day old baby with seizure having neonatal stroke?
Yes, thank you. Very, very good question.
Yeah.
And to the previous question of HIE, so we miss this sometimes because we think it's HIE. It can certainly mimic HIE. The baby, I was making the point, the baby's attached to a sick placenta, so they come out acidotic and low APGAR scores, etc. Many babies will enter an HIE protocol with an appropriate diagnosis of probable HIE, and only on day 4, when we do our MRI, do we find the stroke. But specifically to your question, you have to use your clinical judgment and suspicion. If they are, side-locked unilateral focal seizures, that's a hint. If your EEG looks asymmetrical, so you've got all changes in one hemisphere, the other hemisphere looks fine, have a low index of suspicion and think about stroke. And if you don't have immediate access to the MRI, maybe do an ultrasound and see if you can, again, maybe you can see some asymmetry between the hemispheres. As soon as it's on a unilateral lesion, it's probably a stroke. And so we're lucky here that if I see a baby with encephalopathy or seizures who I don't have a good explanation for based on clinical grounds. I try to do an MRI same day, but I realize that may not be feasible. So you have to use all the tools available. Just think about stroke. That's the key.
Yeah. I don't know, Dr. Monica or Dr. Sridhar, there's still many questions. We'll finish this talk, or we can continue for some questions.
I think we have to stop because of the time constraint, and we will ask Dr. Kirton to answer them either on the chat box or later on. Thank you very much, Dr. and Dr. Kirton. Yeah.
Thank you so much, Dr. Kirton, and thanks, Dr. Monica and the scientific committee.
Thank you.
Thank you.
You're very welcome. I will go and answer as many as I can in the chat. Thanks very much.
Thank you. So you have to move on. I think every lecture would have required 1 hour each, but for the time constraint, we have to stop here. And I'll introduce our next moderator, Dr. Hafiz, who's a great friend of mine and who is a consultant neonatologist in Cornish Hospital. His great interest is in quality studies. And Hafiz, could you take it up? Yeah.
Hi. Thank you, Monica, for that kind introduction. It's my pleasure, and I'm humbled to introduce Dr. Shankaran. Good to meet you, Dr. Shankaran, again, this time virtually. Hope to see you in Abu Dhabi again sometime soon. So she's somebody who needs no introduction, really, but it's customary. I have to introduce her. So Professor Shankaran has a long-standing academic background. She started her career at the Wayne University School of Medicine in 1975. She went on to lead the neonatal perinatal medicine program at the Detroit Medical Center for almost 3 decades. And as we all know, she has pioneered a lot of work in long-term longitudinal studies and contributed multiple RCTs in mainly the field of neonatal neurology. And her groundbreaking work on whole body hypothermia is what kind of set the standard for the treatment around the world when it was first published in 2005 and just confirmed by other studies and other meta-analysis. So that became a standard of care. Not one to rest on her laurels, Dr. Shankaran went on to do further studies to see if deeper cooling and cooling more preterm babies is going to be beneficial in the background of hypoxic ischemic encephalopathy, and found out it was not a great idea. And those studies were stopped, but we are waiting for the long-term outcomes from those studies. She's continuing to be active in that field. Just to kind of understand the impact of her work on the neonatal outcomes, a photograph of her and one of the first babies who participated in the trial hangs in the hallway of the director of the National Institute of Child Health and Human Developmental Neonatal Research Network as one of the most significant NICHD network contribution in the last 25 years. So without much ado, over to Dr. Shankaran.
Thank you. So let me share screen and okay. So I'm going to talk about neuroprotection. Oops, sorry, that's not the first slide. I'm going to talk about hypoxic ischemic encephalopathy and neuroprotection. So currently the evidence is there for hypothermia therapy for infants with moderate and severe encephalopathy in the high-income countries. I'm going to cover clinical monitoring during hypothermia. I will discuss briefly therapeutic drift in hypothermia therapy, including use in premature infants and use in infants with mild HIE. I will touch on hypothermia in the low and middle income countries and then end with just future directions. So the current evidence for hypothermia therapy for infants with moderate and severe HIE is implementing it at 33.5 degrees Celsius for 72 hours. And of course, this is based on data from the randomized controlled trials in the high-income countries. And to just to give you the overview, the rate of death or disability at 18 to 24 months of age, as you can see in this slide, is reduced between the from the control group to the hypothermia group. In the statistically significant decrease was seen in the NICHD trial from 62 to 44%, from the European trial from 83 to 51%, the trial in China, and the ICE trial from 66 to 51%. If we look at the other outcome, which is cerebral palsy at 18 to 24 months of age, you see that there was a significant decrease between control and hypothermia in the TOBI trial from 41 to 28, the European from 48 to 12, and the trial from China from 28 to 14. The current data on the rate of death or disability actually has been reduced still further with cooling. And currently in the trial that we did evaluating longer and deeper cooling on outcome, we had a rate of death or disability of 29% in the overall group. In the moderate hypothermia infants, it was reduced to 20%. In the severe hypothermia infants, it was reduced from our first trial in the cool group from 72 to 62%. And the mortality rate was reduced from 24% to the current 9%. The number of infants with a mental developmental index or a Bayley-III cognitive score in the normal range has increased from currently to 65%. The psychomotor developmental index or the Bayley-III motor has increased to 68%. Interestingly enough, we did not find a decrease in the rate of cerebral palsy. Now, does neuroprotection with hypothermia persist to childhood? This has also been evaluated very carefully in the CoolCap trial using a maternal interview of 62 of 135 surviving children. It was noted that at 6 to 7 years of age, the disability status at 18 months was strongly correlated with the ratings on the parent interview. There was no significant effective treatment. In the NICHD trial, we evaluated an outcome of death or IQ less than 70. And what we found was that there was a reduction in this outcome from 62 to 47% at 6 to 7 years of age, which was significant in the unadjusted risk ratio. But once we added center, we lost that significance. The secondary outcomes at 6 to 7 years of age showed that there was the reduction in the infants in the hypothermia group, both in mortality or cerebral palsy, and also in death or severe disability. Now, when we switch to the TOBI trial, where the outcome was number of surviving children at 6 to 7 years of age with an IQ greater than 85 from the original trial, you can see that the number of infants in the hypothermia group was 52%, significantly higher than the infants in the control group. The secondary outcomes of the TOBI trial did not show a significant difference in death or in cerebral palsy. So I think this has clearly shown that hypothermia in the high-income countries was effective. So when hypothermia is implemented, what is the monitoring that should occur? Probably the most important thing is the selection of the infants for hypothermia. They should be equal to or greater than 36 weeks of age, less than 6 hours of age, which is considered the time of neuroprotection. And infants should be selected who are at highest risk. So that is those with severe birth acidosis, or in the absence of cord blood gases or gases within 1 hour of age, the need for birth resuscitation that is continued for at least 10 minutes. And infants should have moderate or severe encephalopathy. The challenges of a neurologic exam being done so early, within 6 hours of age, is that we have to remember there will be an impact of maternal anesthesia and analgesia. It depends on the severity of the injury and the timing of the injury in the perinatal period to the fetus, the ability of the neonate to recover, any associated conditions, and how good the resuscitation was. So these factors have to be kept into consideration. Here you see the modified SANAT exam where 6 parameters are evaluated: level of consciousness, spontaneous activity, posture, tone, primitive reflexes, and autonomic nervous system. And to be eligible for cooling, the infant should have at least 3 of these parameters in the moderate category or in the severe category. It is important to be very consistent with the neurologic exam, to have clear definitions for the categories of the exam, to certify new examiners and retrain examiners on an annual basis. So now the neonatal exam utilized for the NICHD trials are available for public use, and this is the website. So hypothermia in the trials is to be administered only for infants meeting moderate or severe encephalopathy criteria. What are the other parameters during monitoring? The studies that I've looked at data in the randomized trials, especially the NICHD and the TOBI trial, found that the age of initiation at cooling within the first 6 hours really did not impact on outcome at 18 months. So as long as you cool within that first 6 hours after a good neurologic exam. The location of birth was also not found to be different as far as the outcome. So inborn infants and outborn infants had similar outcomes in the NICHD trial. Again, secondary studies from the NICHD trial showed that 25% of infants with a 10-minute APGAR score of 0 survived without disability at school age. And probably very important is that both the NICHD trial and the COOL-CAT trial noted that elevated temperatures before, in the control group in the trials was associated with adverse outcomes. So therefore, we need to be careful that elevated temperatures before and after hypothermia should be avoided because of abnormalities noted both with MR spectroscopy and also indirect measurements of brain temperature that now shows that injured brains have elevated temperatures even with cooling. The other factors to remember during monitoring is that smaller and sicker infants may require blood pressure support both during induction and during maintenance. 2 of the trials noted that low PCO2s are related to a higher risk of disability, so we should maintain PCO2 in the normal range. Hyperoxia was associated with more injury in the secondary analysis of the COOL-CAT trial. And also both elevations in blood sugar as well, both increased and decreased blood sugar was associated with adverse outcome. So these factors have to be all considered when hypothermia is being administered. Continuous video EEG or an amplitude integrated EEG is probably better than intermittent EEG alone and has been shown to decrease anti-seizure medication use. Another important factor is seizures during rewarming, which by itself is associated with adverse outcome. This was the secondary analysis of the Optimizing Cooling Strategies trial that was recently published. And what was important was that 23% of the infants had actually new onset seizures during the rewarming phase. And the last caution is that both sedation and analgesia should be used with caution, and keep in mind that there can be accumulation of morphine during the cooling process. Now, when we look at other factors, the CSF biomarkers and the heart rate variability are very important tools that are being researched currently. The most predictable indicator of outcome, I think, is MR imaging, and this has been covered already and will be covered in more talks. It's a reliable predictor of outcome as seen in the NICHT trial, the TOBY trial, and the ICE trial. Other factors that we noted was that infants with HIE and cerebral palsy are at high risk for growth failure and for developmental delay. So we should focus on nutrition of these infants right from the time they go home. With a number of questionnaires that were administered to parents of children in the secondary studies that we have done, families of children with disabilities have higher financial, social, and personal needs. And there is a greater need for special education and early intervention services in the infants who are found early on to have cerebral palsy or developmental delay with encephalopathy. Spectroscopy is now coming out as a very good predictor of outcome. Here you see data on the NAA absolute concentration, which is in the first panel to your left, is lower among infants with adverse outcome following moderate or severe encephalopathy. The LAA to NA ratio showing a difference in the normal and adverse infants with an elevated ratio. The NAA to choline ratio and the NAA to creatine ratio also shows a difference between those infants who have normal outcomes and adverse outcomes. So this is going to be an early predictor of outcome in the neonatal period. And there was also a correlation between the absolute NAA and the Bailey scores, both the cognitive score in the first panel to your left, the motor score to your right, and the language score. Again, you can see that the infants with adverse outcomes who are shown in red had much lower concentrations than those who had a good outcome. So this is a very promising predictor of outcome. When you look at the prognostic accuracy of the biomarkers, looking at clinical assessment, cerebral function, MRI, diffusion MRI, and spectroscopy, the highest prediction association with outcome was seen in the absolute NAA concentrations. So the summary that I can tell you is that currently 18-month mortality with hypothermia is 9%. Death or moderate or severe CP is 29%. Disability is 29%. CP remains at 20%. 18-month outcome correlates with 6 or 7-year outcome. And it is really important to follow all infants with HIE at least for 18 months. In childhood, normal IQ is seen in 52% of the children. Cerebral palsy is 19%. And among those who are not disabled, among those without CP, 9% had an IQ of less than 70, and 31% were 70 to 84. Children with CP have multiple hospitalizations, early growth failure, The majority have an IQ less than 70, but 23% have a normal gait. Families with children with disabilities have financial, family, social, and personal challenges. In childhood, 32% of the children require special education services, 7% have behavior problems, and the early neonatal biomarkers of outcome is MR imaging and spectroscopy. Now I want to move on to therapeutic drift in hypothermia. There are publications that hypothermia has been used for postnatal collapse, severe surgical conditions, infants with mild HIE, and in preterm infants. I just want to focus on mild HIE and preterm infants. Looking at hypothermia for mild HIE, the recent surveys have shown that the majority of centers, both in the UK and more recently, as you can see in Vaughan and Toby, in the French registry, a number of these registries and surveys have shown that physicians are currently cooling infants with mild HIE. However, no outcome data has been presented from these reports or from the majority of these reports. Infants with mild HIE have been inadvertently included in the original randomized controlled trials, and there have been 2 meta-analyses presented, both of which have not shown any benefit of cooling in the mild HIE infants that were included in the trials. The first one, first publication had 91 infants, the second one had 117 infants, but you can see adverse outcome was no different in both groups. So are we ready for a randomized controlled trial of hypothermia? For mild HIE, I think it should be done. It should be designed to include infants at highest risk. That means only infants with acidosis or needing birth resuscitation. These infants should be carefully selected based on careful neurologic examination. The current depth and duration of cooling should be used because that's all we know currently, which is 33.5 Celsius for 72 hours. And the primary outcome should be long-term. So it should be cognitive and behavioral outcomes with the robust measures at 5 years of age. If a trial shows that cooling is safe and effective, then it should be offered. But if it is not safe and effective, this treatment can be discontinued. Now, as far as I know, there are no large-scale trials that are ongoing, although many are planned. Moving to the second area of therapeutic drift, this is hypothermia for preterm infants. And the basis for this, I think, is that the AAP guidelines originally included 35-week gestational age infants. But you can see from the Toby registry, from the Vaughan registry, preterm infants were included, and 2 of the randomized controlled trials of hypothermia for HIE, the original trials, did include a few preterm infants. But we don't have any data that's published on these infants. I do think this evidence-based data will be available because there is an ongoing trial of hypothermia for preterm infants. The principal investigator is Rajesh. We are looking at safety outcomes because remember, these are preterms. So hemorrhage, thrombosis, bleeding, acidosis, arrhythmia, NEC, etc. And the primary outcome is death or moderate or severe disability at 22 months corrected age. The sample size is 160 infants with the Bayesian analysis. Infants have all been enrolled. The follow-up is almost complete. The COVID epidemic has delayed some follow-up visits, but this data should be available soon. I also want to talk about hypothermia for encephalopathy in low and middle income countries. This is the HELIX trial that was presented by Dr. Thayal at the PAS last year and is published in Lancet. This trial was designed to look at HIE in low and middle income countries. So the inclusion criteria included infants who required resuscitation at 5 minutes, or who had a 5-minute APGAR score less than 6, and had moderate or severe HIE. Infants with absent heart rate, life-threatening malformations, and those unable to attend follow-up visits were excluded. The sample size was 204 infants per arm to be able to detect a 30% risk difference. So here you have the results of the trial. The neonatal characteristics between the 202 hypothermia infants and the 206 usual care infants, there were no differences. You'll notice that the birth weight of the infants is a little on the low side. This trial was conducted in centers in India, Bangladesh. Now, the short-term outcomes, as can be seen on this slide, did show some disturbing data. There was gastric bleeding, persistent hypotension was increased in the hypothermia group, pulmonary hemorrhage, prolonged blood coagulation also increased in the hypothermia group. So also severe thrombocytopenia, and the mortality rate was increased prior to hospital discharge. When the 18-month outcome was evaluated, death or moderate or severe disability was 50% in the hypothermia and 47% in the control groups, and not different. Mortality up to 18 months was higher in the hypothermia group than in the control group. And then you can see the other secondary outcomes that were evaluated. The rate of microcephaly was actually a little bit higher in this trial than seen in the high-income studies. Spectroscopy was done on a subgroup of infants in the HELIX trial. There was no difference in absolute NAA concentrations and in the lactate to NAA ratio. So the conclusions of the HELIX trial was that cooling therapy, as performed in these hospitals that provided intensive care, did not reduce death or disability on the neurologic exam, nor did it reduce the imaging abnormalities. On the other hand, mortality was increased. The reason for this, has been discussed quite a bit. It's probably because the populations are different in the LMIC trial as opposed to the HIC trials, and that brain injury possibly occurred in the perinatal period due to, partial prolonged hypoxia or acute on chronic hypoxia. And the authors suggested that LMIC research should focus on primary prevention by focusing on improving antenatal and intrapartum care, especially in those areas that have very high disease burden. So what are the future directions for hypothermia for HIE? There are a number of studies that are currently ongoing on hypothermia plus therapies. These include EPO, melatonin, umbilical cord, milking. And of these, I think there's a tremendous amount of anticipation for the HEAL trial, which is hypothermia plus erythropoietin, that is completed and will be presented at the Pediatric Academic Society meetings this year in April. So we are looking at this trial with a great deal of interest. We know from prior published trials that xenon, magnesium sulfate, and topiramate were not found to be beneficial. And the future studies should be adequately powered, as hypothermia for HIE now has, at least in the high-income countries, a decreased mortality. And the gold standard for studies will still be 18 to 24 months. I would like to stop there and see if we have any questions.
Thank you, Dr. Shankaran, for the excellent overview of hypothermia and HIE. We do have a few questions from the audience. I think other people are still typing in. So one question you've already answered, what your view on the HELIX trial is. One of the criticisms of that is that the kind of landscape of healthcare in these countries is quite different. For example, what's available in the cities is quite different from what's available in the rural areas.
Exactly.
So is it ethical to kind of say we shouldn't do it where the facilities exist in such countries, where the standards might be on par with anywhere in the Western world? For example, what's happening in Delhi might not be the same happening in the periphery of Uttar Pradesh in India, for example. What's your view on that?
Well, I think, that it's a little bit difficult to say. If you do have intensive care and inborn infants, and you diagnose encephalopathy within the first 6 hours, I think with adequate consent discussion with the parents, because we still don't have any outcome data of the infants who are currently cooled in LMIC. And that is one of the concerns that I have. So for the centers that currently are cooling, I think it would be good for them to start looking at their follow-up data, looking at the safety and efficacy data. In general, I would say that just because, the trial, first of all, was the largest one that was ever done, was done very meticulously. There was an external data safety monitoring board that evaluated the trial at periodic intervals and evaluated for both, safety and efficacy. And the trial was completely independent. In fact, was led by one of the PIs of the NICHD trials, the DSMB chair. So because of that, I think, I am concerned with the results of the trial. And I think the fact that we had so many babies who ended up with microcephaly. The other factor that I should have stressed was that almost 75% of the infants in this trial had seizures within 6 hours of age, which is much higher than that seen in the high-income country trials. And the acute perinatal sentinel events was much lower. So it looks as if this could be a sort of an injury that occurred earlier in the perinatal period than what we've seen with our HIC trials. So the question comes up, should we really focus a lot on what we can currently do, which is try and improve antenatal care and make sure we avoid, elevated temperatures for these children. I need to mention there is a very large trial that has started in India. It's called the PREVENT trial, which is looking at a very large number of women and infants. And the trial in the first year looks at the baseline data of the mothers and infants. And in the second year of the trial, randomizes women to care bundles, antenatal care bundles, and then looks at the outcomes. So I think that's a good, some data that we are really anxiously waiting for.
Thank you. We have a couple more questions from the audience. One is, I think we all know the answer to this, but for cord gases, which ones do you consider significant, venous or arterial, or either?
Well, either. I'm not, because we really could not get separate, venous and arterial. So we said, whatever is available is fine.
Yeah, that's great. One of the other questions which has come up in seizures associated with HIE, what anticonvulsants are currently recommended? I think it might be coming up in later talks. Do you go for Keppra or phenobarbital, age-old medicine?
You know, it's really up to the clinicians, and I'm sure that Dr. Shellhaas is going to cover it in detail. From my experience within the neonatal network, we tended to use phenobarbital first as the first line, and then use Keppra after that if the seizures were unresponsive.
Okay. One of the other questions is about this is for me actually, the recommendations for neuroimaging. We started doing MRIs a couple of decades ago now. And initially they said a week to 10 days. Now we are doing it earlier and earlier with the advent of diffusion-weighted imaging and spectroscopy. So what's the current recommendations? How early and how late can you neuroimage to kind of prognosticate in these infants?
Well, I mean, I know that our first trial, which was of course 98 is when we started, the imaging was done much later at 2 weeks of age. So now it is done much earlier, usually between day 5 and day 7. I think too early is not. I think you need to wait to see what the injury is. And so between day 5 and day 7. Now the other speakers may have their own opinions on this. The longer, deeper trial was mentioned, and we do have MRIs on the majority of infants in the trial. And currently we are evaluating those MRIs, and we will be looking at the MRIs of infants in that trial.
Dr. DeVries probably will cover in her talk.
Yes, I'm sure she will.
Yeah, one of the other questions which has come through, which again, from the trial data we know, so do we need to wait for neurological symptoms and if we resuscitate newborns, if they meet the cord pH criteria? But we probably know the answer to that. But one of the audience
But again, my own opinion is that you have to wait for the infant to recover from the resuscitation. So you'll notice that in the HEAL trial, the inclusion criteria is after the first hour of age. So you had to wait for the first hour to see the response to resuscitation, and then look and see if the child qualifies for HIE. I am concerned when delivery room temperatures are dropped and cooling is started right in the delivery room. I think that is way too early. So I would suggest, looking at how the child responds to resuscitation, doing an exam and probably repeating it again, and then seeing if the child has moderate or severe HIE.
So that was going to be a follow-on question, this practice of passive cooling, which probably a lot of resuscitation guidelines do mention. So your recommendation would be to avoid that till we have adequate.
Yes, I would, avoid hypothermia, but I would keep the child's temperature normal, in the normal range, while the child is being resuscitated, because you do have to respond to resuscitation.
We have a question from Dr. Rajesh.
Hi, Dr. Seetha. I'm one of the neonatal consultants, colleague of Hafiz. My question is based on what you've just said. We see a lot of babies being cooled based on the neurological examination in the delivery room or during the resuscitation that, he was slightly hypotonic, or there were some signs of not encephalopathy, but like low tone. And this we commonly see, and a lot of our babies are getting cooled based on that. Now, I think your answer, which I'm able to understand from your last answer, is that probably we should wait for an hour at least to review the neurological examination.
Yes, I think you should resuscitate the infant. There are infants with anemia, severe anemia, who are very floppy at birth, and you need to stabilize them, give them a blood transfusion and look at the response to that, and then do the neurologic exam. I do have concerns about initiating cooling in the delivery room. I think it is. I don't think those are babies with moderate or severe HIE. I'm concerned that you're cooling infants who could very well be mild HIE.
True.
One significant question. Sorry.
Mm-hmm. No, so I think that is one of the reasons why in the HEAL trial they were very specific. You had to wait for an hour, and so I'm a little bit curious how the current trial, that is, or the trial that's about to be started on umbilical cord milking. I'm just curious to see how that trial is going to proceed.
There's one question from the audience linking the previous talk to this one. So if, for example, a term baby was encephalopathic and you find intracerebral hemorrhage on your early ultrasound scans, would you continue cooling or not? If you meet the criteria.
That is a very good question. It's a little bit hard to answer because we don't have that many MRIs during the period of cooling, during the 72-hour period. Now, if you have an infant who is severely encephalopathic and continues to be encephalopathic during the period of cooling, and you decide to redirect care, I think that's a different issue. You want to redirect care, you might get an MRI to see what the brain looks like, and the MRI shows hemispheric devastation. That I agree, with ischemia and hemorrhage. That I agree that may help you to make your decision how to, whether to continue cooling or whether to withdraw support. Most of the data on the MRI findings has actually come after the period of cooling.
Okay. There's another question from a low-income country background. This is the use of alternative methods of cooling. I think there have been a few trials on that, like the use of ice bags and water-cooled bags.
Right.
As an alternative method of hypothermia. What's your opinion on that?
Well, I am concerned about that because I think it is really important to have very steady temperature during the period of cooling. So I am concerned when you say, we use ice bags or, so I would suggest using, if you were to use cooling, it would have to be a very, a method of cooling that would provide sustained temperatures. Because these infants are, especially the smaller, sicker infants, have very frequent drops of temperature and very labile temperatures.
I think one of the questions about mild HIE and brain insults. So I think you've already addressed that we need more evidence on that. So
yes, that is my opinion, that we do need to see whether cooling is safe and effective in mild cases. Yes.
Thank you, Dr. Shankaran, for this excellent overview on the topic. If there are no more questions, I think there might be other questions coming up. So if you can stay with us and can answer some in the chat box, that'd be great. It's coming in the Q&A section. While we move on to the next talk with Dr. Davies. Thank you, Dr. Shankaran, so much for your time.
Thank you.
Yeah, Dr. Monica, if you can just take over because Dr. Rajesh is not with scene.
Okay, so they were really excellent talks, and we'll move to the last session. And I would invite Dr. Shiva Shankar, who's a consultant neonatologist and great hospital, and he's also taking care of I think 3-4 more neonatal hospitals to combine them and work as a tertiary level, or I should say 4th level NICU facilities for all of us. So I hand over to you, Dr. Shiva Shankar.
Thank you, Monica.
it's my pleasure to introduce Dr. Renee Shellhaas. Dr. Shellhaas is a clinical professor of pediatrics at the University of Michigan, where she holds the Donita Sullivan Research Professorship and serves as the Director of Research for the Division of Pediatric Neurology, as well as the Associate Chair for Career Development for the Department of Pediatrics. She has served on the Child Neurology Society Executive Committee, American Academy of Pediatrics section on Neurology Executive Committee, and is the co-chair of the American Epilepsy Society's Research and Training Council. Her work on neonatal seizures include discoveries regarding the genetic basis of neonatal epilepsies and optimal treatment duration for acute symptomatic neonatal seizures. Over to you, Dr. Shellhaas, and thank you for sharing your knowledge and expertise.
Thank you so much. It's really an honor to be here, and I have to pinch myself for being allowed to speak after Dr. DeVries and the other outstanding speakers today. So thank you for sticking it out all the way till the end of this outstanding symposium. I'm really excited to talk with you about some new developments in research in neonatal seizures. These are my disclosures. Importantly, there aren't FDA-approved medications to treat neonatal seizures. So we're doing a lot of work off-label. I want to begin with my thank yous. The work that I'm going to present to you comes as a result of really outstanding collaboration with individuals across the United States. I am privileged to work with Dr. Hannah Glass as the co-principal investigator of the Neonatal Seizure Registry, and these are our colleagues at each of our 9 centers. Additionally, at the Neonatal Seizure Registry, we have found that parent and stakeholder input is really essential. And we have a parent from every study site who advises us, as well as representatives from parent advocacy organizations who have helped with our study design, recruitment, retention, interpretation of data, and writing of our manuscripts. I'm going to give you a whirlwind tour of some updates talking about evidence for first-line treatment, talking about evidence for stopping medicines, risk factors for infantile spasms, and recognizing mental health concerns among parents of infants with neonatal seizures. We're all here because we believe that neonatal seizures are common and consequential. We recognize that babies with seizures have a high risk of mortality, and that survivors often, or perhaps usually, have disabilities, which could include cerebral palsy, intellectual disability, or epilepsy. Usually neonatal seizures are considered distinct from epilepsy, but we're making a case to think about them in the context of the way that we think about other seizures in infants. In early 2021, the International League Against Epilepsy released their classification of seizures in the epilepsies with a modification for seizures in the neonate. This really brings neonatal seizures to the forefront. The paper emphasizes the key role of EEG for the diagnosis of neonatal seizures, emphasizes that seizures may have clinical manifestations, but EEG-only seizures are very common. It took me a long time to get my head around this, but if we think about it this way, if the seizure does not begin in the motor cortex or evolve to involve the motor cortex, the baby isn't going to move because of the seizure, and a preverbal infant isn't going to be able to explain a sensory phenomenon associated with the seizure. So EEG-only seizures are very common. Importantly, events that do not have EEG correlate are not seizures and don't need to be treated as such. I recognize that many of you come from institutions and regions where EEG monitoring is really a luxury that can't be applied to every baby. I would refer you back to this paper where they provide some suggestions of how you might look at a baby that you're worried about and decide whether you are confident that they have or have not had seizures. So now that we think about neonatal seizures, we have to think about how we might treat them. And this title of this editorial, after all these years, we still love what doesn't work, really still resonates. This editorial was published in 2005. And after this time, we still are using the same medicines. Phenobarbital remains the first-line treatment for neonatal seizures. This has been true in clinical practice worldwide. It has been very consistent and has not changed over time. Here are some data from the Pediatric Health Information System representing treatment for more than 6,000 infants from nearly 50 North American children's hospitals over a decade of time. And you see on the top that among babies who are treated for neonatal seizures, more than 90% receive phenobarbital. Over that decade, there was an increasing use of levetiracetam, with some babies still receiving phosphenitilin. Sadly, levetiracetam is not as good as we had hoped for neonatal seizures. The NeoLEV-2 trial is really a beautifully and carefully done trial examining the effect of phenobarbital as compared with levetiracetam for EEG-confirmed seizures as the first-line treatment for seizures in newborns. What they found was that 80% of babies who received phenobarbital had their seizures stopped for at least 24 hours. That's much more than the 28% of babies who received levetiracetam. Importantly, no baby who had persistent seizures after phenobarbital had resolution of their seizures when levetiracetam was added. So these data really suggest that levetiracetam should not be in our first or second line treatment pathways for neonatal seizures at this time. The best option really, as we begin to treat neonatal seizures, is to make a plan that makes sense for our local institution, our local intensive care unit, and stick with it every time, because that way we'll have consistent treatment and we'll do the very best that we possibly can. For most of us, we should begin with a loading dose of phenobarbital. If at all possible, have EEG monitoring to help us to determine whether the seizures have resolved. And if they have, then our recommendation is to continue EEG monitoring until the baby has been seizure-free for about 24 hours, and to consider maintenance phenobarbital at least for a few days. And I'll talk with you some more about that in a little bit. If the babies have not resolved, the seizures have not resolved, then again, continuing EEG monitoring if possible, and adding additional phenobarbital to reassess. If seizures continue to persist, then selecting the second and third line agents depends really on the clinical scenario and your local resources. I would refer you to this paper by Jennifer Keene, which outlines a number of different institutions' practice guidelines for neonatal seizure treatment. The second line medicine and further testing for neonatal seizures really depend on etiology. We know that most neonatal seizures are provoked seizures, and many times those babies have subclinical seizures I just told you about, and usually we can identify an acute etiology. Most often it's HIE, maybe hemorrhage or stroke. Those seizures, the natural history is that they resolve within days. And at this point, there is not etiology-specific treatment for the seizures. Contrast that with babies who have neonatal onset epilepsies. And this is encompassing between 10 and 15% of all neonatal seizures. Tonic seizures are very common in these babies. So for an infant who does not have an obvious acute etiology and they're having frequent tonic seizures, please think about epilepsy as the etiology. These babies may have coexisting acute brain injury, but usually they don't. Importantly, most often babies who have neonatal onset epilepsies have an identifiable genetic etiology. Their seizures will persist and they're going to need long-term treatment. And sometimes there is precision therapy that's possible depending on the genetic etiology. So this is a key distinction that I hope you'll all remember, is that it's important to identify, does the infant have acute provoked seizures or is it epilepsy? And if it's epilepsy, right away, think about genetic etiologies. So we agree on how to start medication, phenobarbital for the most part, but how should we stop? In the neonatal seizure registry, we found that treatment duration was variable. There were really two schools of thought and practice. There was a group of institutions where most babies had medicines maintained at the time of hospital discharge, and the medicines were weaned at follow-up at around 3 or 6 months. This has really been the historical approach, and it represented about 3/4 of the first 600 babies that we evaluated in the neonatal seizure registry. Then there was another group whose medicines were discontinued. The medicine was stopped after the acute seizures resolved, and this was backed by safety in some small studies. There was an attempt to do a randomized controlled trial to evaluate maintaining versus discontinuing the medicine, but that failed due to low enrollment. People were nervous, both because they wanted their baby to continue on medicine and they were afraid seizures might return, and because they were concerned that the medicine may cause harm, and that resulted in low enrollment. There were about a quarter of our babies in the neonatal seizure registry who had their medicines discontinued prior to discharge. So we developed a study that we called NSR2, Neonatal Seizure Registry 2, and the objective was to examine the association between duration of anti-seizure medication use and 24-month outcomes among newborns with acute symptomatic seizures who were enrolled in the Neonatal Seizure Registry. The NSR2 was a prospective observational cohort. We enrolled babies at 9 centers across the United States. Every one of these centers has a level 4 neonatal intensive care unit and a level 4 pediatric epilepsy center. And we all follow the American Clinical Neurophysiology Society guidelines for neonatal EEG monitoring. We included babies who had seizure onset at less than 44 weeks postmenstrual age, who had clear acute symptomatic seizures, most of them with HIE, stroke, or hemorrhage, but a smattering of other etiologies as well. And we excluded babies who had a mild transient cause for seizures, for example, hypoglycemia with no brain injury on imaging, who had clinical events that were determined not to be seizures. Importantly, we excluded babies who had early onset epilepsy, and we excluded babies who did not survive the neonatal admission. The primary predictor was going home with or without anti-seizure medicines. So we had a group whose clinicians decided to discontinue the medicine prior to discharge from the neonatal seizure admission, and then we had another group whose clinicians decided to maintain the medicine. The primary outcome measure was something called the WIDEA-FS. This is the Warner Initial Developmental Evaluation of Adaptive and Functional Skills. It's a telephone functional assessment that was conducted by blinded clinical research coordinators. This tool tracks fairly well with the Bailey scores. Secondary outcome that was pre-specified was the incidence of post-neonatal epilepsy. So babies may have had their symptomatic seizures resolved, but after time had unprovoked seizures that began, and so they had an epilepsy diagnosis. We used propensity scoring for the analysis. Just one quick slide on this. This is a statistical technique that uses observational data to estimate treatment effect by accounting for variables that predict the treatment. So what are the variables that I, as the clinical provider at the bedside, might use to determine my decision about how long to continue medicines? The idea here is to reduce bias due to confounding, and it's a tool used to improve causal inference in observational non-randomized trials. We enrolled 305 babies. We had to exclude 2. 21 were lost to follow-up, 3 because they died. And we had 90% of our babies who had a primary outcome to analyze. 2/3 of the babies had their medicine maintained at the time of discharge, and most of those babies went home with phenobarbital monotherapy. There were a handful who had levetiracetam monotherapy, and another handful who had combination therapy with phenobarbital plus levetiracetam. Not surprisingly, babies who went home on anti-seizure medication had higher phenobarbital exposure than babies who went home off of medicine. I want you to just pay attention to the overall treatment. So the median treatment duration for babies who went home off of medicine was 6 days. The median duration for babies who went home on medicine was 4 months. So quite a big difference. Here's another way to look at this with a Kaplan-Meier curve. We see that overall, the median duration of continuing treatment was 4 months. We had 40% still on medicine at 6 months, 20% still on medicine at 12 months. And that wasn't because they necessarily had epilepsy, they just continued their phenobarbital from the NICU. The unadjusted results are presented here, and Dr. Kirton showed you some of this already, but I'm going to re-emphasize it because I think it's really important. What we have here is the box plots of the WIDEA, the functional development score, at 12 months, 18 months, and 24 months. In the purple, the babies who maintained their medicine at the time of discharge. In the gray, the babies who went home off of medicine. And you see that these box plots are really very much overlapping over time. There was no difference in the primary outcome. When we looked at the risk for impaired functional development, as defined as a WIDEA FS score of worse than 2 standard deviations below the normal mean, at age 24 months, there was no difference. About 1/3 of babies had impaired functional development at 2 years of age. In the adjusted analyses, again, there was no difference in the WIDEA FS score at 12 months, 18 months, or 24 months. We powered this study for non-inferiority, and all of the analyses met the a priori non-inferiority limit of 1/2 standard deviation of the WIDEA FS score. We did some pre-specified subgroup analyses. We looked at our preterm babies and again found that the WIDEA FS score at 24 months corrected age was not different for babies who went home on versus off of anti-seizure medicines. And for babies with HIE, again, no difference in functional development at 24 months. Importantly, the risk for epilepsy was also unchanged. Overall, in the cohort, 13% of babies developed post-neonatal epilepsy, and the median age of onset of epilepsy was 7 months. The absolute number was 11% in the group whose anti-seizure medicines were discontinued, and 14% in the babies whose anti-seizure medicines were maintained. The adjusted odds ratio was 1.5 at a very large confidence interval. I want to point out that every infant who had epilepsy at onset less than 4 months of age, which is the median duration for continuing phenobarbital in the babies who went home on medicines, had their anti-seizure medicines maintained at the time of hospital discharge. So they developed epilepsy even though they were already on medicine. Again, I'll show you a survival curve here. This is the survival without epilepsy. Babies who's had their medicines maintained are in the purple and discontinued in the gray. And again, pointing out that all of the babies who had epilepsy at onset less than 4 months were in the maintained group. And I'll tell you some more about this in a minute, but about 1/3 of the babies who developed epilepsy had infantile spasms. Let's talk a little bit more about the profile of post-neonatal epilepsy. About 1/2 of the babies had clearly focal epilepsy. At the last follow-up, 1/2 of the babies had already been seizure-free for more than 6 months. About 1/3 had less than 1 seizure per month, but 11% had really relentless daily seizures. Of note, about 1/3 of these babies already had treatment-resistant epilepsy by the time they were 2 years old. So that means that they had tried 2 appropriately selected anti-seizure medications but continued to have persistent seizures by the time they were 2. And that did not include the medicines they received for their acute neonatal seizures. Other really important take home for me was the very high risk for abnormal development among the babies who had epilepsy. So 81% of the babies who developed postnatal epilepsy had a clear impaired functional development outcome with a WIDEA FS score worse than 2 standard deviations below the normal population mean. And that's compared with 27% of children who did not develop epilepsy. And that's even though 1/2 of the babies were seizure-free for more than 6 months by the time they were 2 years old. So developing post-neonatal epilepsy should be a big marker of risk for abnormal development. When we looked at adjusted models to predict neonatal risk factors to predict epilepsy, there were no surprises here. Babies who had more seizures, so the number of days of neonatal EEG confirmed seizures was a risk factor for epilepsy, and babies who had an abnormal discharge neurologic exam also had a higher risk for seizures for post-neonatal epilepsy. I mentioned infantile spasms a minute ago, and I want to spend a few minutes just to highlight those. Infantile spasms were fortunately rare in this cohort, but they're really important because early diagnosis and treatment of infantile spasms offers the best hope of preserving development. In our cohort, this was 4% of the cohort, but it was about 1/3 of the babies who went on to develop epilepsy. We did a separate analysis of risk factors for infantile spasms in these babies. And we found 3 important factors, 1 EEG, 1 MRI, and 1 clinical. So on EEG, a severely abnormal EEG background or more than 3 days of neonatal EEG confirmed seizures was a risk factor. A deep gray injury or brainstem injury on neonatal MRI, and abnormal tone on discharge exam. And that was just marked as abnormal, whether it be low tone or high tone. And we extracted that from the medical records. What does that look like? Among babies who had none of these 3 risk factors, none of them developed infantile spasms. So they're a relatively low risk group. Babies who had 1 or 2 of these risk factors had the baseline risk for the whole cohort. But babies who had all 3 of these risk factors, more than half of them developed infantile spasms. So a very high risk group. That's important both for counseling and for design of clinical trials that may be attempting to reduce the incidence of infantile spasms. So infantile spasms after acute neonatal seizures can be predicted based on these clinical factors. That's important because it's just 3 things that we can all remember and we can teach to parents. It's really important for parent education. If the baby has no risk factors, you can be very reassuring about infantile spasms. If the baby has all 3, then that baby really requires careful monitoring. Parents need to be very carefully educated about what to look for, and there should be a low threshold for follow-up with a neurologist and for a follow-up EEG. We developed this into the infographic seen on the right side of the screen. This graphic is available on the Neonatal Seizure Registry website, which I've listed below, in English and in Spanish. Please feel free to go to that website and to download this if you find it helpful. To just summarize here, epilepsy prediction after acute provoked neonatal seizures. Staying on an anti-seizure medicine isn't going to help prevent epilepsy. All of our very earliest onset epilepsies were in babies who went home on medicine. There are some babies who need extra close follow-up. Babies who have lots of neonatal seizures, 3 days or more. Babies who have abnormal neuroexam at discharge. Babies who have brainstem injury. If you're not able to do the imaging, one proxy is babies who do not take all oral feeds at the time of discharge from the hospital. And maybe also hemispheric injury. And if you're interested, I can talk to you a bit more about that. But the follow-up EEG that we did at 3 months of age, the babies who had clear hemispheric asymmetry seem to be at a higher risk for epilepsy. So I wonder in my practice whether a follow-up EEG and exam by 2 months of age may be appropriate for high-risk infants to screen for hypsarrhythmia. I want to shift gears for a few minutes before we finish to emphasize something that Dr. Kirton emphasized as well, that parent well-being is really key for child development, and it's important for our babies with neonatal seizures. We worked with our parent partners and with Linda Frank at University of California, San Francisco, to look at associations between infant and parent characteristics and measures of family well-being and parent well-being in newborns in the same cohort of newborns with seizures. At the time of discharge from the neonatal intensive care unit, more than half of our parents had significant symptoms of anxiety, and about 1/3 had depression, or at least symptoms of depression. And those problems persisted over time. So this paper is just now coming out in the last week in children, where we looked at measures that were validated measures of parent well-being at the time of hospital discharge, 12, 18, and 24 months. And what you can see here is that the risk for anxiety in the blue came down a little bit by 12 months of by the baby's first birthday, but it persisted. The risk for depression in the orange similarly came down, but still persisted at more than 10% of the parents. And the risk for possible or probable post-traumatic stress disorder was in more than 1/4 of our families. So this is something that we really definitely need to be paying attention to. The bottom line here is that we have to care for the parent as well as the child. We asked parents to write to us and tell us what would be helpful for them and what advice they had for clinicians. And the themes that came out of this really beautiful analysis by Monica Levin at Duke University included the value of clear and consistent communication, having consensus within the hospital team, and encouraging parents to participate in bedside care. Even the ability to change the baby's diaper or feed them makes a difference for a family. We developed this infographic for parents, which again is available in English and Spanish on the Neonatal Seizure Registry website, to help to share with them that it is understandable and recognize that anxiety and depression are common for our families and that there are some challenges, and also that many of our families shared sources of strength. There are some links on this infographic to relevant, reliable peer support as well. Bedside communication really matters, and that was highlighted by the parents who wrote to us, both at the time of NICU discharge, but also later on over the course of their child's first 2 years. They emphasized to us that it really is important that we learn to communicate effectively with parents and amongst ourselves, that we provide resources and support for the baby, but also for their families, and that we understand and validate the parent experience. And once again, this infographic is available on our website. So concluding this part about discontinuing anti-seizure medicines, I want you to take home from this talk that stopping medicines early after acute symptomatic neonatal seizures resolves after a few days is safe. It won't impair functional development. It won't increase the risk of epilepsy. And in fact, when we did some additional analyses, it seemed to be associated with improved parent well-being. And I would say then that there's no real rationale for continuing the medicine. There's no benefit to neurodevelopmental outcome for going home on medicine. It prolongs exposure to medicines that potentially have side effects. It won't delay the onset of epilepsy. In our cohort, the earliest onset epilepsies occurred in spite of maintaining medicines. And we know that for epilepsy with onset at less than 12 months, levetiracetam actually is better at controlling seizures than phenobarbital. This is different from the acute treatment of newly diagnosed neonatal seizures. But so if your baby does come back and develop epilepsy, there's a different medicine aside from phenobarbital that may work better. A third of early epilepsy is infantile spasms, and we know that infantile spasms do not respond to phenobarbital and levetiracetam. So overall, the evidence supports discontinuing anti-seizure medicines for most babies with acute symptomatic seizures prior to discharge from the hospital. If you're still nervous, I would encourage you to think about using MRI and genetic testing to exclude newborns with neonatal onset epilepsy and confirm their acute symptomatic etiology. To monitor, if at all possible, according to the American Clinical Neurophysiology Society guidelines, to ensure that the seizures, those acute seizures, really have resolved, and to wait to stop the medicines until the clinical course for the baby is improving. So it doesn't mean you have to stop instantly, but that within a few days, you're probably okay to stop. And that there's no need or rationale to transition to a different medicine prior to discharge home. What we studied here was going home off of every medicine as compared with any medicine. So it's okay to just go home off of medicine. So to summarize for you, I showed you that slide from the editorial from 2005 saying, after all these years, we still love what doesn't work. And that's a little depressing, but there are new developments in neonatal seizures. We talked about the fact that the ILAE underscores the role of EEG monitoring. I talked briefly about the importance of distinguishing acute symptomatic neonatal seizures from neonatal onset epilepsy. And that really key distinction that babies who have neonatal onset epilepsy very often have an identifiable genetic etiology. And those genetic etiologies sometimes have precision therapy options. That phenobarbital remains the first line medication for neonatal seizure treatment, but that early treatment discontinuation is safe. And parent well-being is likely to influence children's outcomes. So we have a clear opportunity to screen for anxiety and depression and to offer resources to families at the time they go home from the neonatal intensive care unit. I'd like to thank again my outstanding collaborators with the Neonatal Seizure Registry, fabulous stakeholders, thank our funding resources and the wonderful clinical research coordinators at every site, as well as, of course, the children and their families. If you want more information about the work that we've done, please refer to the Neonatal Seizure Registry website that I've listed below, or send me a message. I'd be happy to talk with you. And I'm delighted to answer any questions that you may have.
Thank you, Professor. Let me start my video. Okay. Thank you very much for an excellent talk. Your data on the discontinuation of medication and the take-home message is quite striking and a revelation, and I'm sure will make us think hard when we are trying to prescribe the anti-seizure medications for neonates at the time of discharge. There are a few questions which has come, and first one is, what's your advice for the management of neonates where EEG is not readily available? Because there'll be quite a few situations in resource limited settings where, what would be your advice on that?
Right. Thank you. And I realize that I come from a place where I'm completely spoiled and we have EEG monitoring available whenever we want it. I also think that it's very important that our research does use EEG confirmation to make sure that the data we are reporting out really are about babies who had true seizures. If you don't have EEG monitoring available or amplitude integrated EEG monitoring available, then you're looking for clinically apparent signs of a baby who's encephalopathic, has a known or suspected acute brain injury, and has consistent patterns of abnormal movements. I mentioned to you that our babies who had neonatal onset epilepsy were most often going to have tonic seizures, and so that's a really important sign for you to look for focal tonic seizures. And then the last thing I would mention on this is that because of immature myelination, newborns don't have generalized onset seizures. So if a baby in front of you is having movements that really appear bilateral generalized from the beginning, it may well be that that's posturing or another abnormal movement, but that is not seizure, because neonatal seizures are focal in origin.
Thank you. Another question about, I think you mentioned in your talk that if the baby remains seizure-free for a few days, then you're safe to stop. And the next question from one of them is along those lines, as in acute symptomatic seizures, how long should the neonatal be seizure-free before we start tapering the anticonvulsants? And do we need to do an EEG before stopping the drug?
Good question. So in our study, the median exposure was 6 days in the babies who went home off of anti-seizure medicines. So if you think about a baby who was cooled, that was our most common etiology, was HIE. They were cooled and they rewarmed on day 4, and then the medicine was continued for a couple more days. The baby started to look better, and then the medicine was stopped. Phenobarbital has a very long half-life, and so there's no need to wean that medicine when it's been only used for a few days, or even a week or two. You can simply stop it and the level will gradually decline naturally, so you don't need to taper it.
Again, something along, you mentioned initially that the events without EEG evidence are not seizures. Again, along a question along those lines, where if a baby is having an abnormal neurological examination, but a normal EEG, what do we do?
Good question. So if your baby has an abnormal exam and has EEG running and has their event that you're concerned about, but there's no EEG correlate, that event doesn't necessarily mean that that event is normal, but it wasn't a seizure, and anti-seizure medicines are not going to stop those from happening. And so I think it's very important to distinguish if your baby has clinical events that have, and you have EEG running and there's no change on the EEG, those aren't seizures. And so we need to perhaps look at, do they have a movement disorder? Do they have epistotonic posturing? Do they have reflux? What else is going on that maybe is making that baby move abnormally?
And another question on what's your opinion on the use of lignocaine as a first-line anti-seizure medication? One of the person is asked.
Good question. So lidocaine, I will say in the United States, there are very few people who use it. Our center does have it. It's part of our protocols. However, most babies will have seizures stop with their loading doses of phenobarbital, if you look at all comers. And so to me, it makes sense to give a less morbid medicine first, because if the seizures go away, then you're done. However, if you've given several loading doses of phenobarbital and a baby is still having very frequent seizures, I think there's definitely a role for lidocaine as the next step, if you have the appropriate monitoring available.
The next question is on starting the anticonvulsants, where one of them asks, bearing in mind that most seizures are subclinical, is it necessary to have an abnormal EEG to start anticonvulsant treatment? Because sometimes they may not be available, the EEG monitoring may not be available.
So we want to be careful that we're treating seizures and not something else. And I would not advocate for prophylactic anti-seizure medicine for every baby who has risk. But I would want additional confirmatory evidence, if at all possible. Whether that evidence be your clinical exam and their abnormal paroxysmal movements, or an EEG or AEG, whatever you have available. And I would refer you back to the ILAE paper from 2021 in epilepsia, which has some more information about how confident you may or may not be with without EEG available, depending on the clinical scenario.
And another person has asked a question on the interaction between phenobarbital and caffeine. So does the use of phenobarbital interfere with the effect of caffeine, or can the caffeine interfere with the effect of phenobarbital?
It's a very good question, and I don't know the answer. I don't think I've ever seen there be a clinically important interaction, but I don't know the pharmacology based on that. I see Dr. Mathur doing this, so I'm hoping he agrees with me.
And infantile, and another person, I'm just trying to read here, infantile spasm prediction tool is an externally validated tool or applicable in level 4 setups only, as most of the centers are not able to get an amplitude integrated EEG. So it looks like more as a comment. Do you have any?
Yeah, so this prediction tool was done across the 9 centers or 7 centers actually at the Neonatal Seizure Registry. We haven't done a second validation study, although we're working to get data to do that. So you can take that for what it's worth. I think the results are really interesting. I think they're intuitively appropriate, and do seem to identify our babies who are going to be at high risk, who need careful follow-up.
You mentioned a very important area of the families requiring quite a lot of support, especially in babies with these. So do you refer them to psychologists? Is one of the questions that is asked by one of the audience.
That's a really good question. I think there are lots of different approaches, and again, resources are variable. I think it is clear that at the time that we're making diagnoses and treating babies for seizures, we need to be looking at parents. And as Dr. Kirton emphasized, if it's not their fault, they need to hear it loud and clear. It's not their fault. And to normalize the truth that many or most parents who go through this really traumatic experience have anxiety, depression, and may develop PTSD, and that's not something to be ashamed of, and that there are resources available, I think is really important. And what resources are available are going to vary, from my town to the next town over. So knowing what your local resources are is also important. Here in my institution, we have a social worker who will see all of our families and can help us to try to guide. But I also am very spoiled in that many of our families follow with obstetrics right in my institution. And so we can reach out easily to their obstetricians or primary care providers as well to help guide counseling. The other thing that is available for everybody, if they have access to the internet, is online parent support groups. And there are some really outstanding examples. Hand to Hold is a great resource for families of babies who have been in the NICU regardless of their diagnosis. Hope for HIE does really outstanding outreach for families who are experiencing HIE for their babies. So I think looking to appropriate family support online can really help to break down some of the barriers to access to longer term support and connection.
Another person asks, is there a role for seizure?
I'm very sorry, there was a glitch in the internet and I didn't hear your question. Could you repeat it?
Sure, it's my internet is playing up. One person asked, what's the role of carbamazepine in epilepsy that develops after a neonatal seizure?
Great question. So there are several case reports or case series of using carbamazepine for neonatal onset epilepsies. Carbamazepine seems to be quite effective for babies who have potassium channel related epilepsies, KCNQ2, for example, KCNQ3. And so that is definitely a go-to medicine for babies with neonatal onset epilepsy. For infants who develop focal epilepsy, carbamazepine or oxcarbazepine may certainly have a role. The data that I have personally analyzed, we had fewer babies with oxcarbazepine or carbamazepine in our sample, so we couldn't have a really robust statistical analysis as compared with levetiracetam. The main question for infants past the neonatal period is, what is their etiology, and do they really have focal epilepsy, or do they have mixed or generalized epilepsy? If they have mixed or generalized epilepsy, carbamazepine or oxcarbazepine may actually make things worse. And so if you're not sure, I think levetiracetam is a reasonable choice because it has a broad spectrum of action and effect, again, for post-neonatal epilepsy, not for neonatal seizures, but for babies if they develop epilepsy later.
Another person asks, do you recommend anti-seizure treatment for hypoglycemic seizures?
If it's really just hypoglycemia, fix the sugar and then see how the baby does. There are certainly some babies who have severe hypoglycemia and have really obvious brain injury if you do the imaging, and they may need more treatment, but the first step should be to fix the glucose.
And are there any EEG patterns of seizures that might give a clue towards whether you can discontinue or continue anti-seizure medications?
Good question. So in our statistical models, we looked at EEG patterns and we did both descriptions of the EEG from the clinical reports as well as central review of the broad tracing. And it didn't matter, is the bottom line, that the risk of developing abnormal functional development or epilepsy was not different whether the baby went home on or off medicine. Having a very abnormal EEG is certainly a risk factor for abnormal outcomes. So don't hear me wrong there, but whether they go home on or off of medicine doesn't change that.
As you can imagine, there are plenty of questions, and I would request if you're able to answer them on that. Before that, I was going to ask if any of the moderators had any questions, direct questions to Dr. Renee Shellhaas.
I had, but I don't know, Rajesh, time is over. Can I? You're muted. You're muted, Rajesh.
So I would suggest, I think we should close now because in some part of the world it's quite late, almost past midnight. I would like to thank all the eminent speakers, moderators, my colleagues, scientific committee, Taufeeq at the not last but not the least, in organizing such a wonderful symposium. Dr. Amit, special thanks to you for arranging all this. We at Neonatal Society in UAE are trying to have at least quarterly symposiums like this, which we are of educational value. And I'm very happy to see this is first time I've seen 1,000+ delegates attending it. And even till last, at the end of Dr. Renee's lecture, there were 850+ attendees who were still listening. So we managed to keep them linked to their computer for 4 hours or plus 4 hours, which is great. And that shows the quality of speakers, the quality of lectures, which has been presented. So once again, I would like to thank everyone from UAE Organizing Committee. Special thanks to Dr. Amit and all the speakers, please. I'm sure we will hear from you all in future again sometime. And thank you for your precious and valuable time. Taufeeq and Dr. Amit, if you have to like to say something, Dr. Amit.
Yeah, I just want to thank you, Dr. Rajesh. I just want to put in a plug. If people are interested in neonatal neurology, please consider joining the Newborn Brain Society. There are special membership offerings for LMIC physicians. It's a great resource, educational resource, videos, lectures, especially for trainees. Thank you.
And Taufeeq, thank you. And last word from you, because you have been the main support and technical everything behind this symposium.
Thank you very much for this wonderful panel. And we enjoyed a lot, definitely, like inshallah. Just a note about the certificates. So the certificates, CME certificates will be sent to all the delegates within a couple of weeks, inshallah. Okay? So thank you again. Thanks for all the speakers and the NNF committee here in UAE. Thanks again. Okay?
And last but not the least, I would like to say special thanks to Monica, because she's the main person behind, along with Dr. Amit, who have liaised together to put up this good show. Thank you very much.
Thank you, Monica.
Thank you, Dr. Linda. Thank you, everybody. Really, we were all blessed to have you here. We were just seeing you in your books, and to have you here was really a blessing for all of us, really.
Thank you. Bye-bye, and hope to see you all in future. Bye-bye.
Thank you everyone. Bye.